So this module, we're going to discuss the gastrointestinal system and medications of the gastrointestinal system. This first slide I really like. It's showing the inside of the stomach, which is showing a little green bacteria. It's actually a very tough bacteria since it can live on the inside of the stomach at very low pHs, so a very acidic environment, and it's called Heliobacter pylori, or H. pylori for short. And this particular organism was discovered about 25 years ago. Is responsible for most conditions of peptic ulcers in the stomach or the duodenum, and also some causes of gastritis, which is inflammation of the stomach. And both of those conditions, especially gastric ulcers or chronic gastritis, which is chronic inflammation of the stomach, can lead to gastric cancer later in life. So if you have chronic inflammation of an organ, that puts you at risk for for cancer later in life. On the right, it shows you 3 pills coming down the esophagus, and that's because we use what's called triple therapy now for treating peptic ulcers, which for the most part, as I mentioned, are caused by this bacteria, H. pylori. So because it's a very resistant bacteria, it usually takes a combination of antibiotics. Amoxicillin and metronidazole are very common ones. There's other ones as well that we'll discuss later. Plus an antacid. So we often use what's called a proton pump inhibitor as the antacid. We'll talk about those. Plus a liquid antacid such as Pepto-Bismol, which has bismuth in it. And bismuth is a chemical that well, first of all, it turns your stools black. But also, H. pylori does not like living in an environment with bismuth in it. So 2 antibiotics, strong antacid, plus bismuth, which is in Pepto-Bismol. Okay, let's go on to the next slide. So we're on slide 2, showing a picture of someone holding their chest, and that's meant to represent gastroesophageal reflux disease, GERD. So let's talk about that first. So GERD is reflux of acid from the stomach into the esophagus. And the cells and the tissue of the esophagus are really not made to see very low pHs that are in stomach acid. So the esophagus gets irritated, and this will lead to the symptoms that people have with gastroesophageal reflux disease. So typically it'll be lower chest pain, burning, nausea, sometimes burping. Often the sensation is a burning sensation, so a burning chest pain. And you can actually have reflux all the way up into your throat. And some people actually have a chronic cough from reflux, since when they lie down at night, they reflux acid, and they aspirate some of it into their lungs, and it leads to a chronic cough. So the gastric acid reflux can cause a number of problems with the lower esophagus. So it can cause just some inflammation, esophagitis, and that's your typical symptom of reflux, the burning lower chest pain. It can also cause esophageal ulcers, where not only do you have inflammation, but now you have patchy little divots missing, ulcerations that go deeper than the inflammation, and that's called ulceration, as opposed to just inflammation. And over time, when you have inflammation, that can lead to scarring of the lower esophagus. So you can get you can have stenosis, which is a tightening and a narrowing of the esophagus. So people can start to complain of difficulty swallowing food. If it gets really bad, you'd have difficulty swallowing liquids. And finally, if you have chronic inflammation of the lower esophagus, that puts you at risk for precancerous lesions that are called Barrett's esophagus. And Barrett's esophagus is really cellular changes of the lower esophageal cells that are precancerous. And if that continues, then you can develop esophageal cancer, which is typically a very aggressive cancer. So it's not only treating the symptoms of gastroesophageal reflux disease, but you also want to treat the long-term risks that come with it, okay? And we use a variety of medications and lifestyle changes, and also sometimes surgery. In terms of medications, we're going to talk about H2 blockers, so histamine 2 blockers. We're going to talk about proton pump inhibitors. And we're going to talk about briefly about some other medications that can help with gastroesophageal reflux. Now, another big part of treating gastroesophageal reflux is lifestyle modifications, weight loss. So anything that puts extra pressure on your abdomen is going to put extra pressure within your stomach, and that will lead to refluxing of acid into the esophagus. So, for example, the type of work you do. If you do a lot of lifting and straining, well, that force on your abdomen is going to translate into reflux. Obesity often will lead to reflux disease. Pregnancy. A lot of women that are pregnant have gastroesophageal reflux. Large meals at bedtime. That can lead to reflux, so your stomach is filled with meals and now you're lying flat. So it's increased pressure by lying flat and also by having food in your stomach prior to bedtime. So there's a lot of advice that we can give people to minimize the symptoms even before going on medication. The other part is medications. So there's many people that are on non-steroidal anti-inflammatories. That can cause gastritis. They can lead to peptic ulcer disease. They can also lead to irritation of the esophagus. So we'll talk a bit about those as well. Okay, so peptic ulcer disease. What are the primary causes of peptic ulcer disease? Well, the first one that we know or are aware of in the past, say, 25 to 30 years is this very hardy bacteria called H. pylori, or Heliobacter pylori. And that is responsible for 50% or likely even greater of all causes of peptic ulcer disease. And when we say peptic ulcer disease, we mean gastric ulcers or duodenal ulcers combined. Duodenal ulcers are ulcers that when treated heal and you're done with them. Gastric ulcers are a bit different because gastric ulcers can sometimes have cancer within the ulcer. So they often need a follow-up gastroscopy or a follow-up reassessment to make sure that the gastric ulcer was purely just from either the bacteria or a medication and not due to carcinoma of the stomach. So anyways, when you think of peptic ulcer, think of both stomach, which is gastric, and duodenal. The other causes of ulcers are medications. And don't forget, it's often a combination of these. It doesn't have to be one in isolation, but medications is a big group that can lead to ulcers. So non-steroidal anti-inflammatories are a huge cause of either gastritis or peptic ulcer disease. Remember, when you're thinking of NSAIDs, think of the side effects that are very common to NSAIDs when people are taking them. So stomach problems, either gastritis or peptic ulcer. Kidney problems. They're very hard on the kidneys since the kidneys are reliant on prostaglandins and NSAIDs inhibit them. So kidney disease, don't take NSAIDs. Heart disease, don't take NSAIDs. Hypertension, don't take NSAIDs. So anyone who has a history of, say, peptic ulcer disease should be very careful with NSAIDs. Kidney disease, same thing. Heart disease and hypertension. We tend to avoid NSAIDs because they aggravate all of those conditions. Corticosteroids such as prednisone, dexamethasone, we use for all kinds of inflammatory conditions, autoimmune conditions. They are irritants of the stomach. They can lead to peptic ulcer disease, bleeding ulcers. We advise patients that if you're taking corticosteroids or NSAIDs, you need to be aware of this risk factor, that it could upset your stomach, it could lead to an ulcer, they could even lead to a bleeding ulcer, okay? And another very common one is alcohol. So alcohol is a direct gastric irritant. It causes inflammation of the stomach, which then leads to ulceration and peptic ulcer disease. Rare causes, a gastrinoma is a cancer that releases very high amounts of gastrin, which then leads to very, very low pHs from the stimulation of the gastrin, and that can lead to multiple ulcers in the stomach. Acute stress. So that one is referring to some kind of either some huge physical stress, such as a car accident, or you've become extremely ill with sepsis, which is infection of the bloodstream with bacteria. So a very acute stress to the body can lead to stress ulcers in the stomach. Okay, so we actually call them stress ulcers. And it's because the body is coping with another enormous illness, such as a massive pneumonia, a car accident, a massive burn. The stomach is still producing large amounts of acid. You're not eating very much. And because of this huge stress response, that patient's at risk for stress ulcers. Malignancy we spoke about, so gastric cancers can lead to ulcers, and that's why a peptic ulcer in the stomach we usually reassess after the treatment to make sure there's no cancer within it. Inflammatory conditions, so Crohn's disease, remember, is a disease from the mouth to the anus. You can get ulcerations anywhere in the gastrointestinal tract with Crohn's disease. So that can cause ulcerations in the stomach, and you're left with a peptic ulcer disease, right? So remember, Crohn's is a widespread disease of the gastrointestinal tract, unlike ulcerative colitis, which is purely in the colon. Ulcerative colitis never leaves the colon. Okay, so let's talk about some lifestyle changes. And before we get to ulcers, let's talk about gastroesophageal reflux disease and some lifestyle changes there. So remember, anything that causes acid to reflux back into the esophagus can lead to lower esophageal irritation and esophagitis. So one of the biggest risk factors for gastroesophageal reflux disease is obesity. So advising patients on weight loss can make a huge difference by reducing abdominal pressure and forcing the acid into the esophagus. Remember, there's a sphincter between the esophagus and the stomach called the lower esophageal sphincter, and normally it prevents acid from refluxing back up. Under certain conditions where the pressure is high, one being obesity, within the abdomen, the pressure is high. This will lead to opening of the esophageal sphincter and causing acid to reflux back up. Another condition that people can get is what's called a hiatus hernia. And a hiatus hernia is where normally the esophagus goes through the diaphragm and then drains into the stomach. A hiatus hernia is where the stomach has herniated through the diaphragm, and now part of your upper stomach is in the thoracic cavity when the esophagus drains into it. So it's lost its function of the lower esophageal sphincter, and people with hiatus hernia are more prone to get gastroesophageal reflux disease because their lower esophageal sphincter doesn't function as well. Okay? Avoiding lying down after a large meal, definitely a good idea to avoid reflux disease. And also at bedtime as well. Avoiding large meals at bedtime is a good idea. In fact, people that have gastroesophageal reflux, it's a better idea to have smaller meals more frequently as opposed to 2 or 3 large meals in a day. Often we tell patients to raise the head of the bed with some blocks, even just a little bit, 2, 3, 4 inches. So not to raise their head with pillows, but to raise the head of the entire bed with blocks, just to have gravity keep the acid in the stomach as opposed to refluxing up while trying to sleep. Smoking. So smoking is a risk factor because when you smoke, you're actually swallowing. You're not only inhaling the chemicals of the smoke, you're actually swallowing the chemicals as well. And that can cause irritation of the lower esophagus, irritation of the stomach, so gastritis, and it predisposes to gastroesophageal reflux. So reducing smoking, reducing alcohol. Alcohol is a direct toxin to the stomach, and it's an irritant of the lower esophagus. So in fact, smoking and alcohol are 2 big risk factors for esophageal cancer, right? So they're both chemicals that irritate the lower esophagus. Someone with mild symptoms of gastroesophageal reflux disease, like say for example, they go out and they have a larger meal than usual. Sometimes all it takes is to advise them to take an antacid pill, or such as Tums or Gaviscon, just to settle down the symptoms. somebody who's getting this daily is completely different. They need a daily medication to prevent this acidic fluid uh, from irritating their lower esophagus. So the pills don't prevent the reflux, but the pills change the pH. They increase the pH. It's not as acidic anymore, so it doesn't irritate the lower esophagus. So it's more the lifestyle changes that reduce the refluxing of the acid, and the medication increases the pH of the stomach fluid, causing less irritation. Now, if you're on a medication for reflux disease and it persists, meaning it doesn't get better, you continue to have burning lower chest pain, so symptoms of irritation of the lower esophagus, despite medication, then that often means that the patient will require testing, such as a gastroscope, so a scope that goes into the esophagus and stomach to make sure that it's not a more sinister condition, such as a cancer. Okay, so onto this page, lifestyle changes now. So we spoke about gastroesophageal reflux disease a bit. And for ulcers, so if you're on medications, not crushing the medications, good idea. Some medications can be direct irritants to the stomach lining. So if it's suggested not to crush them, then probably a good idea. Reducing fat content is a good idea, and also increasing exercise. Increasing exercise actually is a good idea for overall gastrointestinal health. It prevents constipation. It maintains normal peristalsis of the gastrointestinal system. People that lie in bed in hospitals are very prone to constipation and requiring laxatives or enemas. So definitely increasing exercise is a good idea. Eliminating alcohol and smoking. Well, we spoke about those as being direct gastric irritants. So that those would be two risk factors for peptic ulcer disease. Noting which foods, so carbonated drinks, caffeine is an irritant to the stomach. Very spicy food can cause gastritis of the stomach. Reducing stress in your life can definitely reduce peptic ulcers, since stress can cause further secretion of acid into the stomach. That's not the same as stress ulcers that we spoke about under circumstances of acute illness, such as a pneumonia or sepsis or a car accident. And another big risk factor is chronic daily use of non-steroidal anti-inflammatories, and that would include aspirin. So whether it's aspirin or ibuprofen or one of the other ones, so daily use puts you at risk for peptic ulcer disease. Okay, so as mentioned on a previous slide, the vast majority of peptic ulcer disease, whether it's gastric or duodenal, is caused by this little bacteria called H. pylori. And there's different ways of diagnosing this particular bacteria. We have special breath tests that can diagnose it's called a urea breath test, so it tests the amount of urea that someone's breathing out, and that can help indicate whether someone has this bacteria in their stomach. There's direct biopsying of the ulcer, so with a gastroscope, they would take little biopsies around the ulcer or within the ulcer and then culture it for this bacteria. You can test for it in the bloodstream, the antibodies to H. pylori, and you can also test the stools to see if the antigens of the bacteria are within the stool. So there's many ways of testing for this little bacteria. This slide is showing you different treatments, different treatment combinations that are available. I don't think it's necessary to memorize this slide. It's just giving you, not everyone can take one of these. Sometimes you might be allergic to penicillin. So you wouldn't be able to take amoxicillin if that was the case. So a different one would be used, such as number 3, which has clarithromycin and metronidazole. So you'll see that it's a combination typically of 2 antibiotics. So let's look at the first one, amoxicillin and clarithromycin, which is a macrolide antibiotic, plus a PPI, a proton pump inhibitor, and one of the most common ones, and actually the first one, is omeprazole, which is the brand name Losec. And you would take all 3 of these, often in combination with Pepto-Bismol. Remember, that has bismuth in it, and typically for 10 to 14 days. The second combination is amoxicillin with metronidazole, and the third is clarithromycin with metronidazole. And these are just 3 different options depending on which one the person can tolerate and what allergies they have. So this isn't always easy to tolerate, because remember, you're taking 2 antibiotics, which can give side effects of nausea, vomiting, diarrhea, plus a strong antacid, the PPI, plus the Pepto-Bismol. So I don't think you need to memorize these, just have an idea that it's 2 antibiotics with a powerful antacid plus Pepto-Bismol. Okay, so what about treatment of these conditions? So whether we're talking about gastroesophageal reflux disease, and we want to increase the pH or reduce the acidity of the liquid in the stomach that's refluxing, or someone has gastritis, which is inflammation of the stomach, or as part of triple therapy, we'll use one of these medications. Usually it's the PPI. So what about just gastroesophageal reflux? Well, as mentioned, if it's infrequent, you can just use over-the-counter antacids. And as we'll get to in a minute, these are typically magnesium-based or aluminum-based antacid. Milk of magnesia is a very common one. Aluminum hydroxide, and we'll talk about these. And they basically just neutralize the stomach acid so that when it's refluxing, it's not burning the lower esophagus and giving you symptoms. H2 blockers, so if you remember H1 blockers, so antihistamines, commonly used for allergies, allergic rhinitis, allergic conjunctivitis of the eye, allergic rashes. Well, H2 blockers, you have H2 receptors in the stomach, and when you block the H2 receptors, it reduces acid secretion. So there's a few H2 blockers that we'll talk about that have been around for a long time, that have been used for reducing the acidity of the stomach fluid. And lastly, the most powerful group, and probably the most effective group for reducing acidity and treating gastroesophageal reflux disease are the proton pump inhibitors. And they've been out for about 25 years now. As I said, the first one was omeprazole, and there's quite a few in that group now. And they directly inhibit the last step in the acid secretion process. They're direct proton pump inhibitors, and they really reduce the acidity within the stomach. So they're very effective at treating gastroesophageal reflux. So any one of these is typically used in combination with lifestyle changes to have a positive effect on the symptoms of gastroesophageal reflux disease. Okay, so again, I don't think it's necessary on this slide to memorize all of these. It's just to get an idea of the groups and maybe know a prototype of the group. So when we're talking about H2 receptors, and look at the ending of all of these, they're going to have very similar endings. So cimetidine, famotidine, nizatidine, and ranitidine. So the common ones would be, well, they're all common, but the ones that, the oldest one is cimetidine. And when we discuss that one, it had some side effects that were not tolerable. So other H2 receptor antagonists were produced that had less side effects, very well tolerated, and reduced the acidity to control gastroesophageal reflux disease. So ranitidine, for example, is a very popular treatment for GERD. In fact, in many countries, ranitidine is now over-the-counter. It does not require a prescription. So remember, H2 receptors in the stomach are inhibited by these cells, which then produces the acidity of the fluid within the stomach. Okay, the next group, proton pump inhibitors, they all end in prazole. The first one that was produced was omeprazole, and then the other ones have gradually come out over the years. They're all very effective at reducing stomach acid production and also at reducing the acidity in the fluid of the stomach. So even though people are still refluxing, unless they change their lifestyle, the irritation caused by the fluid is really minimized because it's not acidic fluid. Okay. The next group, antacids that we'll talk about, these are basically liquid antacids, aluminum hydroxide, magnesium carbonate, and then there's combinations of ones that have aluminum and magnesium. And we'll discuss that shortly, but magnesium is a laxative as well. So not only is it an antacid, it's also used as a laxative. And a perfect example of that is milk of magnesia. We give milk of magnesia all the time for constipation. It's also an antacid, but if given enough, it'll lead to diarrhea. So some companies have produced a combination of magnesium-based and aluminum-based antacids because aluminum tends to be a bit constipating. So the thinking was, well, if I make an antacid that has aluminum and magnesium, maybe it'll even itself out and not cause constipation and not cause diarrhea. So that's why you'll see the combinations of aluminum and magnesium. The bottom one there, we will talk about sucralfate in a bit. The other ones, the chelates, we won't talk about, but you'll see that bismuth is in there. So bismuth is, as I mentioned before, is in Pepto-Bismol, and typically, people typically take that for an upset stomach, for reflux disease. People travel with it if they have gastrointestinal symptoms. So it's pretty popular to take. Not the most effective medication, but it's definitely used in the treatment of peptic ulcers, as I mentioned before, because that particular little bacteria does not like to live with bismuth around. So let's look at our first prototype medication, aluminum hydroxide. So this is just an over-the-counter antacid, and under similar, it's showing you some other over-the-counter antacids, but that's where the similarity ends, because the other ones aren't aluminum, right? So calcium carbonate would be Tums, magnesium hydroxide would be some similarity of milk and magnesia, so that would be more constipated, more of a laxative as well, since it's magnesium based. And sodium bicarbonate is just baking soda. So, all right. So indications: peptic ulcer disease. As we spoke about before, usually with peptic ulcer disease, you would use triple therapy with antibiotics, an oral antacid pill plus bismuth. But definitely someone who has intermittent gastroesophageal disease could use an oral, a liquid antacid, or a pill antacid such as Tums. So all this does is just raises the pH so that when the fluid refluxes, it's not irritating the esophagus as much. And by raising the pH, it tends to inactivate some of the stomach enzymes that work at very low pH, such as pepsin. So basically it's just an acid neutralizer. Aluminum-based antacids are more constipating, and that's why some have magnesium added to them to try and even it out so that you don't get constipation or diarrhea. Bowel obstruction, well, that makes sense. Aluminum hydroxide is an antacid that leads to constipation, so you wouldn't use it in someone who has a bowel obstruction or has a risk for bowel obstruction. And the big thing to remember with aluminum-based antacids is that they're safe in renal failure, unlike some of the magnesium-based antacids. Okay, the next medication prototype is ranitidine or Zantac, and you can see that they all end in idine. So famotidine would be Pepcid, cimetidine would be Tagamet. I don't think you need to know all the brand names, but you might recognize some of them. And the indications, these can be used in combination with antibiotics and Pepto-Bismol to treat duodenal and gastric ulcers, but in real life, typically we use the PPIs because they're much more powerful. They're often used to treat GERD, heartburn. Zollinger-Ellison syndrome is basically a gastrinoma. So that's a tumor that's secreting high levels of gastrin. Not a common cancer, by the way, and resulting in very high acid levels in the stomach, leading to ulcers. So basically can be used in H. pylori therapy with antibiotics, but typically not because of the PPIs, which are more effective. We spoke about the action being an H2 blocker on parietal cells, leading to reduced acid production. So what are what are the adverse effects? So the vast majority of people do not have any effects at all. Sometimes it can lead, ranitidine can cause headaches, fatigue, sometimes confusion in older people, and then constipation and diarrhea. So gastrointestinal side effects. I guess you can remember it since it's a gastrointestinal drug. So they would be the most common. But fatigue and drowsiness in older people can also happen. Taking this medication at nighttime is often recommended. Some people take it twice a day. The advantage of taking it at nighttime as well, so in the morning and at night, is that you're suppressing the acid on an empty stomach through the evening. As mentioned before, another medication, the first medication in this group was cimetidine. And I think we're going to get to it. But this also caused fatigue, but it also resulted in gynecomastia in males and loss of libido. So because of those relatively uncommon side effects, but common enough that it was felt to produce other H2 blockers, it's not used as commonly anymore, the cimetidine. The other issue with cimetidine is that it interacted with many, many medications, so it made it difficult to take. Now, back to ranitidine. Can be taken with or without food. Typically, you wouldn't take it with antacids, though. So, when I say antacids, it gets confusing because they're all antacids, but like liquid antacids, such as Tums or aluminum hydroxide, since it will reduce the absorption of this drug. So when you're taking an H2 blocker such as ranitidine, remember the lifestyle advice as well. So avoiding overeating, because you're going to get reflux from overeating. Irritating food or medications to the stomach. So caffeinated beverages, coffee, tea. Advising to quit smoking because that's an irritant to the stomach. Trying to avoid NSAIDs. Trying to avoid aspirin unless the indication is for reduction in heart disease or avoidance of a TIA or a stroke. Okay. Okay, so next prototype medication is omeprazole, which is a proton pump inhibitor in the stomach. And all the other ones, again, they all end in prazole. And these are the most effective and powerful group for acid suppression. So they're often combined with antibiotics and bismuth to treat an active duodenal or gastric ulcer. Many people take this for gastroesophageal reflux. I think they're over the counter now in many countries. We use it in the treatment of Zollinger-Ellison syndrome, which is just a long term for gastrinoma, to reduce the acid in the stomach. And of course, as I mentioned, the treatment of H. pylori. So this really suppresses acid in the stomach, which makes it a very effective drug. So when the PPIs came out, they really became first-line treatment for many conditions of the stomach. What about adverse effects? So again, they're mostly gastrointestinal effects: nausea, diarrhea, abdominal pain. There is a bit of there is a bit of a concern of a vitamin B12 deficiency or this medication leading to it. It does suppress acid secretion. So then the question of whether B12 is properly bound to intrinsic factor so that it can be absorbed in the distal ileum. There was also a concern about this medication leading to osteoporosis from malabsorption of calcium. And it's the same idea with B12, it's malabsorption of B12. And then the other concern is because you're removing the acid to such an extent in the stomach, more bacteria can get through the stomach. Because remember that the stomach usually has a pH of 2, 3, or 4, which is extremely low, and most bacteria are destroyed when, say, they're eaten with food or they just make it into your stomach. They're destroyed, so it's very protective to the body. So there has been a concern that by elevating the pH and reducing the acidity of the stomach puts you at risk for more infections. And the reason that it's recommended to increase calcium and vitamin D is because of the risk of the malabsorption of the calcium. Although this particular concern is debatable. The drug's been out for about 25 years, but it's still debatable whether it truly leads to osteoporosis. So the next one is sucralfate. And sucralfate is, it turns into, think of it as turning it into a paste. So it can be used in oral ulcers. It can be used in, say, stomatitis, which is oral ulcers from chemotherapy, gastroesophageal reflux, because once it's into the stomach, it breaks down and becomes almost like toothpaste, and it binds to open areas such as inflamed areas or ulcers. It's not commonly used as much anymore because of the PPIs, which would be first line for gastrointestinal or gastroesophageal reflux, and peptic ulcer disease. But since you have to know a bit about it, just think of it as a medication that breaks down and binds to the inflamed area in the stomach, say for gastritis, or it can bind to the ulcer and form a thick protective layer or paste at that site. Okay, and the same thing would happen in the mouth for oral ulcers after, say, radiation or chemotherapy. So because it turns into this hard paste, if you're taking it regularly, there's a chance that you can form a hard, solid ball of it in your stomach, which is called a bezoar. And a bezoar is basically just a medication that is just bound together and is turned into a small mass within the stomach, and it's not absorbed. Okay, so again, adverse effects, they're all gastrointestinal side effects, plus the bezoar, which is just that hard collection of the sucralfate within the stomach. Nursing responsibilities, so given 4 times a day, that makes it difficult compared to a PPI, which is usually once a day, sometimes twice a day, but most of the time it's once a day. 1 hour prior to meals and at bedtime. And typically you avoid other antacids with it. And remember, because it forms a paste, it can lead to constipation. So fluids are recommended to avoid that side effect. Misoprostol is not used very commonly anymore, and we'll get to the reason in a minute. It used to be combined with certain non-steroidal anti-inflammatories with the idea that, well, the NSAID irritates the stomach, and misoprostol stimulates mucus production of the stomach lining, so it would offset the irritation of the NSAID. Unfortunately, misoprostol is a prostaglandin analog, and it can produce tremendous amounts of abdominal cramping. It's a stimulant to the gastrointestinal tract, so abdominal pain, nausea, lots of diarrhea. Remember, misoprostol is also comes in a gel to put on the cervix to cause cervical ripening and to induce labor. So it cannot be used in pregnancy because of that effect, whether given orally or as a cream. But orally it was used as a protective agent for NSAIDs. There it says about labor induction and cervical ripening. Much less commonly used because of the tremendous diarrhea that you get with it. Not a bad idea to do a pregnancy test prior to drug administration to make sure that someone isn't pregnant. Anyways, the PPIs have been shown to be more effective as a protection to the stomach if you have to be on non-steroidal anti-inflammatories. But I think it's still good to know the medication, that it produces a protective mucus layer and also stimulates the uterus and causes cervical ripening. Okay, so the next medication here is metoclopropamide, which is Reglan. In the indications here, this drug has two actions. So the first one is it's very effective at helping contractions of the stomach and improving and speeding up gastric emptying. But the other one is that it can be a very effective anti-nauseant as well. Okay, so two useful effects. So let's look at the indications. Chemotherapy and radiation-induced nausea and vomiting. Okay, perfect. It has anti-nauseant effects at the vomit center in the brain. And it's going to help with gastric emptying to get the food out of the stomach faster. So post-operative nausea and vomiting, can use some metoclopropamide to speed up the emptying of the stomach. Gastroesophageal reflux disease, well, one of the problems is that there's a lot of food in the stomach that's causing increased pressure and causing reflux, so this medication can help with stomach emptying. Hyperemesis of pregnancy, well, there's lots of vomiting in that, so it, as an anti-nauseant and helping empty the stomach. Metoclopropamide is safe in pregnancy, so it can be used for that. And diabetics get a condition called gastroparesis. So gastro, stomach, paresis, meaning reduced function, almost like a paralysis of the stomach. And that's because the nerves are affected in the gastrointestinal tract by diabetes. So they get, quote, a lazy stomach. And metoclopropamide, because it increases gastric peristalsis, will also help in gastroparesis to empty the stomach. So effective for quite a few conditions. If you remember the effects of it, you'll probably remember the indications more. So the actions, upper intestinal muscle contractions, So that's the peristalsis of the stomach, which will lead to faster emptying of stomach. It will decrease the esophageal, relaxation, preventing reflux. But just by the active movement of stomach contents out and down into the duodenum, there'll be less to reflux and the anti-nauseant effects of this drug. The problem with this drug is it leads to extrapyramidal side effects, dystonic reactions. So it has anti-dopamine effects in the brain, so it can lead to tardive dyskinesia, akathisia, so dystonic reactions that can be extremely uncomfortable. It has sedating effects in the brain, so sedation and fatigue. And the last one, breast discharge, if you're wondering about. So because it has anti-dopamine effects, so dopamine stops prolactin from being released in the brain. So if you block dopamine, you're allowing more prolactin to be secreted by the anterior pituitary, which can then lead to some breast discharge. Okay, so that's the reasoning for that. So contraindications, if you have a history of extrapyramidal symptoms, Parkinson's disease, since patients with Parkinson's disease are very reliant on their dopamine levels, and this has anti-dopaminergic effect. Sorry about that. So anyone with Parkinson's disease, it would not receive this medication. Okay. Remember the EPS side effects, because they would be big with this medication, as they are with some of the antipsychotics like haloperidol and other medication and other antipsychotics that lead to EPS. So what can we do if someone has extrapyramidal side effects to any medication, whether it's an antipsychotic or metoclopramide? Well, you would stop the medication, but if they're acute side effects, meaning they need something now because of their stiff muscles, their dystonia, or their akathisia. Akathisia means the sensation that you're always having to move when you're not really moving at all, but you just can't stop. It's a very uncomfortable side effect. So we use one of two medications to stop it. We can use Benadryl, which is diphenhydramine, and that stops it, or a medication that you may have heard from last semester called Cogentin, it's called benztropine, and the brand name is called Cogentin, and that tends to stop the acute EPS effects. Okay, so let's go on. We're going to just shift gears and go on to talk about some laxatives, some bowel preps. Some of them are unpleasant to take, which you'll realize by looking at some of these videos. In general, if you need a colonoscopy, the colon has to be cleared of stool. So in order to have proper visualization of the colon, you cannot have any stool left there. So you really need a complete purge or a cleansing of the colon in order to for the endoscopist to have a look at the colon. So that's what this is just showing you in terms of the different colors, and really it has to be very clear in order to be ready for a colonoscopy. Okay, so this slide is just going to show you different preps um, for preparation of a colonoscopy. So a common one is bisacodyl, which is Dulcolax, and polyethylene glycol. Another term for that is Go Lightly. There's other terms for it as well, Miralax. There's nothing Go Lightly about it. It's typically a 4-liter jug that you drink the night before, and it'll completely clear your colon. It's difficult to get through the 4 liters. So bisacodyl is a stimulant laxative. So when we say stimulant laxatives, it's going to actively get the bowel to contract and forcibly move things along to cleanse out the bowel. Okay, so this next slide on categories of laxatives and stool softeners. I think this will help clarify it. So bulking agents are just going to be medications that absorb fluid. So they retain fluid in the bowel, which is going to also mean that you need to drink fluids, because if you don't drink fluids, they won't be effective. And this just makes bowel movements easier and movement of stool easier. Just by bulking up the stool, it makes it easier to go through the gastrointestinal tract, and to avoid constipation. So this would be products that would be high in fiber, in psyllium. So psyllium would be in Metamucil, say, for example. But important to take fluids with them. Now, this particular group is used to avoid constipation. They're not very effective to treat constipation, but to avoid constipation, sure. They can also be used to treat diarrhea. And the reasoning for that is because they require fluids. When you take these medications, they absorb fluid in the gastrointestinal tract. So they can take some of that fluid that would have been diarrhea and absorb some of it. So it can reduce diarrhea. And sometimes these are used in conditions such as Crohn's disease or chronic diarrheal illnesses, where you want to absorb some of the fluid. So constipation or diarrhea in the first group. Stool softeners, they don't stimulate the bowel at all. They are used again to prevent constipation. So a very common one would be called docusate, used very commonly in hospitals to prevent constipation, especially if you're on an opioid medication post-operatively. You'll often be given docusate to prevent constipation. And they really just allow fluid to more easily enter the stool, and making it a bit, well, they have in quotation slippery here. Again, they're not laxatives at all. Okay, so now we'll head to some laxative type medications. So lubricant medications, so mineral oil. All it does is it softens the stool. It's an oil product, and it makes it easier to pass the stool. The next one are hydrating agents. So So these agents, hydrating agents or osmotic laxatives, what they're doing is they're increasing the osmolarity within the gastrointestinal lumen, so it's forcing fluid into the lumen or keeping fluid in the lumen. And examples of these would be lactulose, peg light, which is, quote, go lightly. And these are very effective to treat constipation because you're forcing fluid to stay in the gastrointestinal tract. They're also very effective, such as peg light, for cleansing or purging the bowel before a procedure. Okay, milk of magnesia makes this group, and again, it's a laxative that's commonly used. Once someone becomes constipated, docusate, which is a stool softener, isn't very effective, so we would move on to something like milk of magnesia or lactulose to help people have a bowel movement. In the bottom group, so prostaglandin analogs. So we've spoken about prostaglandin analogs, misoprostol. That was the main side effect of it, that it stimulates the bowel to have to increase peristalsis. So that's why it caused diarrhea, abdominal discomfort. Prokinetic agents. Well, we spoke about a prokinetic agent called metoclopropamide, and that stimulates also peristalsis. So we use it, and we used it for other reasons, but it can be used for this. Typically, prostaglandin analogs and prokinetics aren't used as much for constipation. The stimulant laxatives, I think I missed that one, are medications such as bisacodyl is the most would definitely make this group. The brand name for that is Dulcolax, and that actively stimulates colon contractions. Okay, you definitely wouldn't use this. Well, you wouldn't use any of these in bowel obstructions, but a stimulant laxative would probably be the worst since you're actively forcing the bowel to contract. So stimulant laxatives help by increasing peristalsis and moving the stool along through the gastrointestinal tract. And at the bottom you can see Cascara, bisacodyl, and Senecot. So those are all common medications where if we really want to get things going, we could use Senecot, Cascara, or bisacodyl. But remember, the side effect is going to be abdominal cramps, abdominal discomfort, because you're really stimulating the bowel to work. Okay, so let's talk about psyllium next. The brand name would be Metamucil, and it's listing some similar medications underneath, such as bisacodyl and Mireloil, but the similarity ends when we talk about the different groups they're in. So psyllium is just a bulking agent, okay? So it's not like the other ones where they have different actions. So because it's a bulking agent, you can use it in constipation as long as you're drinking a good amount of fluids, or you can use it in diarrheal illnesses. So for example, under indications there, someone with irritable bowel can have constipation and diarrhea. That's kind of the definition of irritable bowel. It's this alternating diarrheal illness with constipation, abdominal cramps. So psyllium can be used in that. Someone with chronic diarrhea, such as in Crohn's disease or diverticulosis, sometimes you might have chronic diarrhea. Someone with an ileostomy definitely has diarrhea because An ileostomy is where it's been diverted to the abdominal wall and the stool never made it into the colon for reabsorption of water. So they have very liquidy stools. And psyllium can be used to absorb some of that liquid. Okay? So it's a bulking agent. So because it's a bulking agent, you're going to get bloating. You're going to get gas. But typically, people take this very well. Any of these medications would be contraindicated in an active bowel obstruction. Okay, so any laxative. Because if you have a bowel obstruction, that needs to be dealt with prior to trying to force food or fluid through a bowel obstruction. It's just going to cause more pain. In fecal impaction, so fecal impaction is where you have a tremendous amount of stool in your lower colon typically, and it's impacted. It's become hard Play-Doh. So adding psyllium, which could actually increase the stool there, since it increases, well, without increasing your fluid intake, it can aggravate fecal impaction, right? So we wouldn't use it to try and clear fecal impaction. Fecal impaction often needs manual disimpaction from below, and some of the stronger laxatives up above. Drinking fluids with psyllium, especially if you're treating constipation, is really important, since that's how it works. It absorbs fluids and helps with bulking up the stools. Increasing fiber in the diet, drinking psyllium with lots of water, always a good idea. Okay, so next one, we're shifting to diarrheal illnesses. So diphenoxylate with atropine, so that's low motil. Another one similar to it is loperamide. So this will slow down diarrhea. Now, you don't always want to slow down diarrhea, especially if it's infectious diarrhea. So this would be someone who has either chronic diarrhea or someone who is going on a road trip and they just need something to stop the diarrhea while they're in the car. Okay? But in general, for acute diarrheal illnesses, which are typically infectious, you wouldn't take a medication to slow down the diarrhea. The other indication is definitely with an ileostomy. We spoke about that you have very liquidy stools, and that's normal with an ileostomy. And sometimes you need to either take something like psyllium, which will bulk it up a bit, or something that will slow down peristalsis, such as diphenoxylate. So why does it work? Well, it's a type of opioid. And opioids, one of the main side effects of opioids are constipation, because they slow down peristalsis, and they allow more water to be reabsorbed into the body. So you get just solidifying of the stools. What about the side effects? Well, you're gonna have a bit of opioid type side effects. So dizziness, lethargy. There is potential for addiction and abuse. And again, it is a CNS depressant at very high doses because of the opioid, which is the diphenoxylate in it. Megacolon, if someone were to abuse this drug, they would become severely constipated. And severe constipation can lead to basically a plugging of the colon and dilation of the colon, because you've slowed down peristalsis so much that the colon isn't contracting. And it's not that you have an obstruction, but because the colon's just not contracting or has peristalsis, it dilates, and you can get something called megacolon, which can be quite dangerous because megacolon can continue to dilate and then finally perforate. So if you hear of toxic megacolon in, say, someone with C. difficile infection, well, there's so much gas being produced by the C. diff infection that they're at risk for toxic megacolon that can lead to perforation. So megacolon in the setting of diphenoxylate or low motil would only be if it was highly abused. Okay. In general, under contraindications, don't take this medication with any diarrheal illness. You want to flush the infectious diarrhea out. You don't want to slow it down and keep it in the gastrointestinal tract. The atropine is added for a number of reasons. The first one is atropine is the prototype anticholinergic drug, right? So anticholinergic, which is anti-parasympathetic, slows down the gastrointestinal tract. So that will also help with the diarrhea because it's slowing down peristalsis. The other reason why atropine is added is it's going to make it much less likely to abuse this medication because of the atropine side effects, right? Blurry vision because of dilated pupils, dry mouth, constipation, tachycardia, urine retention. So atropine's added just to not only have the effect that you want, which is slowing down the diarrheal illness, but also to avoid abuse. And remember, the big thing about diarrhea is to encourage proper fluid intake, because these people will get dehydrated. And electrolyte abnormalities, right? So they can lose sodium, they can lose potassium and magnesium, and so often we keep if someone with severe diarrhea, we'll keep an eye on their sodium and potassium, and encourage fluids, not just water, but an assortment of fluids that will have some electrolytes in them. Under the notes, I just had a couple of other things. So I can see bismuth is mentioned again, whether it's in Pepto-Bismol or kaopectate. So let's just briefly talk about it. We've mentioned it in the treatment of peptic ulcer disease as an additive to that tritherapy, which is 2 antibiotics and a PPI. But bismuth itself, it's going to turn your stools black, right? So there's 3 things that make your stools turn black. So blood, bleeding in the gastrointestinal tract, especially from the upper gastrointestinal tract, the stomach or the duodenum or the esophagus. And why is that? Because it's had time to be digested as it goes through the gastrointestinal tract, and it turns black and becomes melena. Iron pills turn your stools black, which can be confusing because that can look like blood. And bismuth turns your stools black. Okay. The other medication I see listed here is glucocorticoids. So glucocorticoids are really not gastrointestinal drugs, but they can be used for someone who's very ill and losing tremendous amounts of weight from either chemotherapy, a cancer illness, often in cancer, you lose your appetite. And on top of that, you're receiving radiation or chemotherapy. So glucocorticoids are appetite stimulants. So they can stimulate hunger in patients that have lost their appetite. So that's where they come in. And the other one on this in the notes is apripitant, which treats chemotherapy-induced nausea and vomiting. I don't think it's an overly common drug. It acts at the vomit center. It can be used in combination with, say, ondansetron or metoclopramide to try and control nausea and vomiting. After chemotherapy treatment. Okay, so we're switching gears again, and we're going to talk about a medication that's commonly used for Crohn's disease or ulcerative colitis. So sulfasalazine. Okay. There's a number of different brands in this group, but basically sulfasalazine is a drug that has two components to it. It's got an aspirin compound and it has a sulfa group. And definitely the aspirin part has an anti-inflammatory effect in the bowel, and of course in the colon. So it can treat Crohn's disease or ulcerative colitis. Okay. The side effects really come from the sulfa group that's attached to it. Okay, and we'll get to those in a minute. Okay, so sulfasalazine for ulcerative colitis, which is, as you know, a colon-only disease. It's an inflammatory condition of the colon that it's an autoimmune disease as well that can lead to diarrhea, bloody stools, abdominal cramping, and often needs treatment with anti-inflammatories such as sulfasalazine or sometimes corticosteroids to control it. Crohn's disease is a mouth to anus inflammatory disease, which isn't superficial. It's not the superficial layer of the intestine. It's typically full thickness. It goes right from the inner lining of the intestinal wall right through to the outer layer. Okay, so it's a full thickness inflammatory condition, and that's why Crohn's disease often leads to a lot of problems. It can lead to obstruction in the small intestine. It leads to all kinds of ulcerations because it's full thickness. It can attach itself to other parts of the body because the outer part of the intestine is inflamed as well. So it can attach to the bladder, and then you can get a fistula there, where now you're urinating stool because of the fistula, or it can attach to the vagina, and now you have vaginal stool discharge because of the fistula there. So it can be a very unpleasant disease. The small intestine can attach to the abdominal wall and form a fistula right outside through your abdominal wall, and you can have leakage of stool through your abdominal skin. So anyway, so how does this drug work? Well, because it has aspirin in it, it inhibits prostaglandins, leukotrienes, and reduces inflammation. What are the main side effects? So nausea, vomiting, diarrhea. Okay, that could happen from the aspirin compound or from the sulfa compound in it. But everything else really comes from sulfa. And if you remember Septra, which is an antibiotic, sulfamethoxazole in trimethoprim was Septra. You remember that, it has that nasty rash called Stevens-Johnson syndrome that involves, can involve any part of the skin, but also the mucous membranes of your mouth, of your eyes, of the vagina. So Stevens-Johnson syndrome is a severe rash, not common, but severe. Sulfas can also give you a mild hepatitis, so liver toxicity and bone marrow suppression, so myelosuppression from sulfa. So a lot of these side effects are really from that sulfa group. Contraindications, well, allergic to sulfa or aspirin, or liver issues, right? Nursing responsibility. The first thing is you really want to see the effectiveness of this drug, and you should expect reduced diarrhea, reduced bloody stools, reduced abdominal pain, and this is a maintenance drug. People will take this for years to control their colitis. The other thing to remember about sulfa drugs is you can be photosensitive, meaning if you go out in the sunlight, you can develop a rash if you're on a sulfa type medication. So photosensitivity is in there. And monitoring of LFT is because of the mild hepatitis that can happen. Okay, ondansetron. So this is a medication that came out probably about 10 to 15 years ago. A very popular anti-nauseant medication used very frequently in all kinds of nausea and vomiting conditions. So patients coming in or children coming in with nausea and vomiting will often use a dose of ondansetron to try and control it. Initially it was primarily used as a treatment for nausea and vomiting caused by chemotherapy, but now it's really used for any condition that's causing a lot of vomiting. So you'll see there acute vomiting from gastroenteritis. So often even in children that come in and they're vomiting, they can't keep fluids down, we'll give them an oral dissolving tablet under their tongue and wait 30, 60 minutes to see if they can start sipping fluids. Okay. So this particular drug is a serotonin antagonist. It works at the chemoreceptor trigger zone in the brain to try and reduce the stimulation of this area and limit the amount of vomiting. Probably the most common side effect, there aren't many, but the most common side effect would be headache in ondansetron. And it can prolong your QT. So this drug, when it came out, the company accused other companies that, well, your drug prolongs QT and we're going to prove it, and it just so happens that this drug also prolongs QT. So it was kind of touted as that doesn't tend to happen with our drug, but that's not the case. Anyways, so contraindications. Well, if you have a prolonged QT on your ECG, we're probably not going to use a lot of ondansetron. Or if you have arrhythmias or dysrhythmias caused by a prolonged QT, we wouldn't use this. Monitoring fluids and electrolytes, that would go for anyone who has, the treatment that we're using this for is vomiting, so we'd monitor fluid and electrolyte balance. And this is somewhat safe in pregnancy, we tend to use other things first. We might try some metoclopramide first for nausea and vomiting. We might try some diphenhydramine, other medications to offset the vomiting in pregnancy. Ondansetron can be used. It's not necessarily first line though. Okay, so pancreolipase. So this is just replacement, enzyme replacement for the pancreas. So if you have pancreatic deficiency, so the exocrine part of the pancreas, the part that secretes enzymes, not the endocrine, which would be responsible for insulin and glucagon, but the exocrine for digestive juices. So someone who has chronic pancreatitis, say from alcohol abuse, may require pancreolipase, or a patient who has cystic fibrosis, and the pancreas often becomes plugged up with thick, tenacious secretions from the cystic fibrosis, and it doesn't function any longer. They often require pancreolipase. And it does what lipase is supposed to do. It breaks down and converts conversion of lipids and starches and proteins. So it's a mixture of enzymes to help with digestion, since the pancreas isn't working. Side effects, pretty minimal. I mean, you can get gastrointestinal side effects, but because it's helping with digestion and absorption, it's probably going to vastly improve your symptoms, right? So someone who has malabsorption because their pancreas has failed, they often have diarrhea, abdominal pain, greasy stools because they're not absorbing fats. And once you've introduced pancreolipase, those things tend to go away because digestion is now working. The pork allergy, I think it's because this is produced in pigs. Nursing responsibilities, just so assessing abdominal pain. Okay, so it's probably going to improve with this medication. You would assess also for what you would hope for, a reduction in diarrhea, a reduction in steatorrhea, weight gain. So now you're digesting and absorbing, so you should be able to now gain weight because the nutrients are able to be digested and absorbed. The slide on peppermint I will leave to you, since I'm going through time quite a bit here, so I'll let you go through this slide. Okay, as well here for ginger root. I mean, ginger in general has been used for nausea and vomiting for hundreds of years. So, you know, ginger is a very common anti-nauseant. When you buy ginger ale, look on the side of the can or the bottle. See if there's any ginger in it. Most ginger ales now do not have any ginger at all. They're ginger flavored, or they have additives, or there's very few ginger ales that have ginger. Okay, so this next slide is showing you that the vomit center in the brainstem can receive stimulation from many sites in the body to stimulate nausea, or to lead to nausea and vomiting. So it can come from the vestibular system in the inner ear, which is the balance system. There can be diseases of the balance system, such as vertigo, You can get labyrinthitis, which is a problem with the flow, the flow of the endolymph in the vestibular system, and that can lead to balance issues and nausea and vomiting. Some of you, I'm sure, have been seasick. Well, that has to do with the vestibular system. Gastrointestinal issues can lead to nausea and vomiting through signals to the vomit center. Upper brain disorders can lead to vomiting. So, how about a concussion, a head injury? They can lead to nausea and vomiting. So, just keep in mind that nausea and vomiting is often not a gastrointestinal problem. It can be even acute pain. Someone with severe pain can come in nauseated and vomiting. And that's why there's a number of different medications that are used to try and address or to try and inhibit the vomit center. So if you look at this slide, it says ATI Chapter 29, gastrointestinal disorders. You'll see that we may try anticholinergics or antihistamines for the vestibular system. So we might try diphenhydramine. We might try some kind of atropine type compound to control the inputs coming into the vomit center. From the upper brain, might try some cannabinoids. Not very often, but it can be tried. From the gastrointestinal tract, serotonin receptor antagonists. So that would be referring to ondansetron, but we will definitely use diphenhydramine to try and control vomiting from the gastrointestinal system. We might try some metoclopramide. In the upper top right, you'll see serotonin receptor antagonists. That's ondansetron. Antipsychotics. That would likely be referring to either, metoclopramide isn't really an antipsychotic, but there's others in that group, such as haloperidol. Sometimes we'll try for nausea and vomiting. So if someone comes in with severe nausea and vomiting, and we've tried an assortment of medications, we'll often give intravenous haloperidol to try and control it. So a whole mixture of different medications. And because each one works slightly differently, we can use a combination to try and stop the vomiting. So dexamethasone is a corticosteroid, and I mean it's used in an assortment of conditions, right? So, I mean, we use it in COPD flares, we use it in asthma flares, we use corticosteroids in Crohn's disease flares, lupus, ulcerative colitis, and just severe allergic skin reactions. It just goes on and on. And we can use it for someone who is going to receive chemotherapy because of its powerful anti-inflammatory effects, it can reduce the nausea and vomiting after chemotherapy. Okay. I think it's always a good idea to know all the adverse effects of corticosteroids, because if you know them once for one drug, you'll know them for all the corticosteroids, and they just seem to come up in questions. So know the side effects of corticosteroids, right? It's going to affect your sugars if you're diabetic. It's going to increase your sugars, okay? Because it's a hormone that's highly involved in metabolism, and it releases sugars. It has very powerful immunosuppressant effects. It can lead to it can cause people to have emotional changes such as depression or anxiety. So we warn people, your emotions can be altered by this drug. Appetite is really increased when you're on these medications. That's why people gain weight when they're on corticosteroids, or one of the reasons. Hypertension, for sure. Fluid retention. Yep, you reabsorb a lot of fluid from the kidney when you're on corticosteroids. A very puffy moon face, a buffalo hump at the lower neck. It thins bones by blocking osteoblast production of bones. It can lead to peptic ulcer disease and gastritis, we just talked about, that can lead to a bleeding ulcer. It can lead to glaucoma in the eye, high pressures in the eye, and also cataracts in the eye. You're at much higher risk for infection because of the immunosuppression. You bruise much more easily because your skin is much thinner. The tissue of your body, in particular your skin, is much thinner. You're at risk for thrush in your mouth because you're immunosuppressed. So just know the very common side effects of glucocorticoids in general. Okay, I'm going to go through this one very fast. We've mentioned it already. I don't think there's much to it. Apripotent, post-op nausea, vomiting, or chemo-induced nausea, vomiting. I think that's all I'm gonna say on it. I don't think it's a very common medication. Okay, dronabinol. Just I'm sure many are aware that with THC, your appetite is increased, which is a bonus. In patients with wasting diseases such as AIDS, and for chemotherapy-induced nausea and vomiting. So this is an anti-nauseant medication that can be used. Okay, so scopolamine. So scopolamine is an anticholinergic. Sorry, very similar to atropine. And it comes as a patch that can be put behind the ear. It comes as eye drops to dilate the pupil. It can be used subcutaneously. I would say the most common is the patch that goes behind the ear. And it can be very effective for motion sickness, right? It inhibits signals coming into the vomit center. So post-op nausea, vomiting, motion sickness. People put these on before getting on a boat so that they can try and enjoy the boat ride without getting sick. And because it has anticholinergic effects, it's used in palliative care to dry up secretions that aren't being swallowed by the patient that's dying. So people often have secretions in their lungs or in their upper throat that can be very disturbing to hear for the family. And it may be bothering the patient. I think often it bothers the family more, but it can bother the patient as well. And it dries up secretions through its anticholinergic effect. Also, you can use it preoperatively to dry up secretions, say in oral surgery. So you don't want all kinds of mucus in the mouth if there's going to be oral surgery. You can use scopolamine or atropine to dry up the secretions. Okay. So the actions we just spoke about, it interferes with nerve impulses to the vomit center. It's an anticholinergic drug, so you're going to get all those anticholinergic effects and side effects. So some of the effects you want: drying up secretions, controlling nausea and vomiting, but some of the side effects you won't want, the anticholinergic side effects. So the tachycardia, the blurry vision, the constipation. Contraindications we won't go over. We've gone over this before. Nursing responsibility. So side effects. right? This is very anticholinergic. And when you block the cholinergic system in the brain, especially in old people, they get really confused. So you need acetylcholine in the brain to be alert. So when we block it with anticholinergics, you get tired and fatigued. You're at risk of falls and confusion. So when we're talking about anticholinergic side effects, we talk about all those ones that affect the parasympathetic system, the dry mouth, the blurry vision, the tachycardia, the bladder retention, the urine retention, the constipation. But always remember, these are very fatiguing drugs because they block acetylcholine in the brain. They lead to lethargy, off balance, and then finally falls. Okay, so dimenhydrinate, extremely common, often a first-line medication that we use for nausea and vomiting, since it's extremely inexpensive. It's been around for a long time. So you can use this for motion sickness, just like you could use scopolamine. They work differently. Nausea and vomiting, say post-op, or just nausea and vomiting in the emergency room, and dizziness and vertigo. You can try and block the signals coming from the vestibular system with a antihistamine such as this. So this is an antihistamine blocker that tries to block signals coming into the vomit center, right? So just an assortment of different causes of nausea and vomiting, whether it's from the gastrointestinal system, the vestibular system, anything that's leading to nausea and vomiting. Dimenhydrinate can be used for it. And remember, it's just a simple antihistamine that's been marketed for nausea and vomiting. It has anticholinergic side effects. Okay, so because of that, look at the side effects: sedation, fatigue, confusion, right? That's blocking acetylcholine in the brain. So old people that are getting lots of doses of dimenhydrinate are going to develop these side effects. Even young people that take this for a long time can develop sedation and fatigue. And this comes in an assortment of delivery systems. So oral, IM, IV, rectal. It just depends on if the patient's able to take it orally. If they're vomiting, then you're not going to use the liquid or the oral. You're going to give it as some form of an injection or rectally. Okay, so the next drug that we're going to talk about is lorazepam, and I mean lorazepam is more appropriately put in the anti-anxiety, the insomnia treatment type group. So I mean it's a sedative, right? So whether it's diazepam or midazolam, which is Versed, or alprazolam, which is Xanax, they're sedatives. So they can be used in gastrointestinal disorders to try and settle someone a bit. They don't really have direct gastrointestinal effects, though. So can they be used in chemotherapy-induced nausea and vomiting? They can be, but more for their sedative effects. So think of them more as anti-anxiety. They're used for sedation, whether it's sedation because of anxiety or sedation for a procedure, sedation to help with sleeping, insomnia, treatment of ongoing seizures. Benzodiazepines are first line, and alcohol withdrawal. So when you're withdrawing from alcohol, you're you're very agitated and tremulous, and that's what makes it difficult to withdraw from alcohol. And a benzodiazepine can definitely blunt those symptoms to make it easier to withdraw from alcohol. So how does this work? Well, it basically inhibits, or it depresses the CNS by stimulating the GABA system. So gamma aminobutyric acid system is a inhibitory system in the brain, and if you stimulate it, you give more inhibition to the brain. So you'll get sedation, calmness, improved sleeping. So it works through the GABA system, like a lot of drugs work through the GABA system to increase inhibition in the brain. So what are the adverse effects? So sedation is an effect of the drug. You could call it an adverse effect as well, I guess, depending on what you're using it for, but it's also an expected effect, right? Benzodiazepines are addictive, and you can develop dependence on them for sure, and they can be hard to withdraw from, right? And someone who's been on benzodiazepine for months, suddenly stopping them cold turkey could be dangerous, because now their brain has become accustomed to this increased inhibition through the GABA system, and now you're removing the drug, so they can become hyperexcitable, they can become highly agitated, and they can develop seizures. The other risk factor for benzodiazepines, especially in the elderly, is falls, and it's because of the sedation. Nursing responsibilities. So definitely advised for short-term use if possible. It's not always easy to do that, but as the continued use goes on, people will develop dependence and difficulty withdrawing from the medication. Always remember, with benzodiazepines, if someone's taken too much, is respiratory depression, right? It's always an airway issue if given too much benzodiazepine. It's avoided in sleep apnea because it relaxes you so much. It can aggravate sleep apnea and make snoring much worse. It depresses the respiratory system, so that wouldn't be a good idea in COPD. And in the elderly, it's because of the confusion. Definite care when combined with opioids, because opioids can have some of those respiratory depressant effects, fatigue, dizziness. So when combined with a benzodiazepine, they're synergistic. They're additive to each other. Okay, so probiotics. So this is introducing bacteria, so normal flora, back into the system, right? So the most common reason for suggesting probiotics is someone who's taking antibiotics. Okay, so that makes sense. Antibiotics, probiotics. Okay, so now they wouldn't be taken at the exact same time. That would be, that wouldn't make sense, taking the antibiotic and the probiotic at the same time. But they would be used concurrently at different times of the day. And the idea here is to maintain normal gut flora, the gastrointestinal flora or bacteria, while taking the antibiotic. There's no definite evidence in inflammatory bowel disease or irritable bowel disease, or ulcerative colitis, whether it's effective or not. But definitely with someone who's taking a course of an antibiotic, it can maintain normal gastrointestinal flora. We wouldn't give this to someone who's immunosuppressed because you're introducing bacteria into the gut, uh, or premature infants, or someone who's receiving chemotherapy, right? And as I mentioned before, you don't take it at the same time as the antibiotic or the antifungal, since there'll be a neutralizing effect. It'll be 2-3 hours away from the administration of the antibiotic. Okay, so irritable bowel syndrome. So this is a very hard condition to treat. Uh, it's a constellation of symptoms: diarrhea, constipation, abdominal cramps, and there's really no known cause. And at the beginning, when people present or when patients present with these symptoms, we don't immediately diagnose them with irritable bowel syndrome. We rule out more concerning diseases first, and once concerning diseases are ruled out, then we suspect and diagnose irritable bowel syndrome, and it can make life miserable if it's severe in nature. You can miss out on activities, missed work days. You can imagine dealing with severe constipation and diarrhea, or sometimes it even alternates back and forth. Abdominal cramping, lack of appetite. So, and it's often in the younger age group, right? Teenagers, 20-year-olds, and 30-year-olds. And a large percentage of the population have it, around 10%. So, a lot of gastrointestinal clinics are filled with people that have irritable bowel syndrome. Unfortunately, there's not a lot of good treatments for it. So there's suggested uh, options in terms of lifestyle changes and a couple of medications that we'll talk about. So as I mentioned before, eliminating other more concerning conditions is really important. Treatment is really symptomatic. So it just depends on what symptoms they're presenting with, and you'll treat those, right? So it might be asking them to make a dietary diary to see if anything bothers them. Might be trying probiotics, although there's no definite proof there. Often it can involve counseling. Irritable bowel disease has been linked to some of the mental illnesses, so depression or anxiety. There's been a link there. Never will you see anything abnormal on testing or in the stool. So bleeding stool, so blood and stool would never be a symptom of irritable bowel syndrome, or any other test that shows up another reason to have their symptoms. So really there's no lab test or imaging test that would diagnose irritable bowel syndrome. So we think it's likely a combination of genetics of the patient, a psychological makeup of the patient, and environmental causes that are leading to these symptoms. And you can see there's some advice on the right there on this slide. Exercise, making sure that you're drinking really well, meditation techniques, maintaining fiber-rich foods, eating fruit, and things to avoid, such as gastrointestinal irritants, caffeine, alcohol, carbonated drinks, spicy food, a lot of processed foods, a lot of fatty and high carbohydrate foods, avoiding overeating. Try smaller portions instead of large meals. Okay, so there's a lot of advice for irritable bowel syndrome. Unfortunately, there aren't a lot of great medications for it. Okay, so let's talk about a couple of medications. So remember, with irritable bowel syndrome, this is symptomatic treatment. Okay, you're not curing the disease. You're just trying to help them with their symptoms. And the vast majority of the time, that'll consist of dietary advice, counseling, ideas on how to manage lifestyle. So let's look at this drug, uh, olesitron. Okay, indicated in females only with IBS. That's already very concerning. So only females can take this drug, and the reason why is it was harming, and I think it was deadly in some males that took this drug. So that already should be an indicator that maybe this drug is not a good idea, since half the population cannot take it. Selective blockade of serotonin receptors, resulting in stools with increased firmness and decreased urgency and frequency. Okay, so it can help with irritable bowel with diarrhea. You'd have to be pretty ill with irritable bowel syndrome to be taking this drug because of the side effects that half the population can't take it because it was so dangerous to them. So adverse effect, well, constipation, since that's one of the, you're taking this for IBS with diarrhea, so it could lead the other way and cause constipation. And if constipation became severe, it could lead to a bowel obstruction. Contraindications, men. Okay, that should be an indication not to take a drug. If it says contraindications, men or women. And it was due to ischemic colitis, which is basically loss of blood supply to the gut. Patients need to see their healthcare provider monthly, and a lot of strict guidelines. So this would be a pretty rare drug to take. You'd have to be very ill with irritable bowel syndrome. Okay, lubiprostone. I'm not going to spend a lot of time with this drug either. Again, need to be probably pretty ill to be taking these drugs. And this is irritable bowel syndrome with constipation this time. So one was with diarrhea, is with constipation. Since this will loosen the stools a bit, okay. And it could be used for chronic constipation. I don't think it is very often, but it could be. So adverse effects, poorly tolerated GI side effects. I don't think you're going to see this medication very often. And you wouldn't give it to someone with diarrhea already, since it has bowel movement loosening effects already. So maybe just know the difference, that one causes constipation, one causes diarrhea. And remember, irritable bowel syndrome, some people present with mainly constipation, some people present with mainly diarrhea. Okay, so maybe just knowing which one would be used with IBS with constipation, which one would be used IBS with diarrhea, and which one wouldn't be used in half the population, i.e. males. Okay, so the rest of this module, we're going to go over some reproductive medications, some hormones that exist in males and females, the differences between them, some medications that are used for BPH, benign prostatic hypertrophy. So we'll just slowly go through this and make some sense of it. Okay, so estrogens as a prototype. So there's many types of estrogens on the market. So let's just get an idea of what an estrogen is. Now, one of the main female hormones is estrogen, the other being progesterone. And we often want to use estrogen for different medical conditions. So it comes in pills, it comes in patches, it comes intravenously for different indications. So let's look at some of the more common indications for estrogen. Definitely when it's combined with progesterone in a pill or a patch, it's very effective as a contraception. So a contraceptive pill, birth control pill. As well, it's used in combination with progesterone to control acne in young females. So another indication, so someone who wants the contraception and also has acne, there's certain birth control pills that have the indication for obviously birth control and also for acne. We use estrogen in postmenopausal women for menopausal symptoms, hot flashes, depressive symptoms, night sweats, all kinds of symptoms that postmenopausal women can get. The other thing that postmenopausal women can get, or if you're a female that for whatever reason had ovarian failure prematurely, like say at the age of 40, or you needed to have your ovaries removed, then you would go on to estrogen therapy. And one of the main reasons to go on to estrogen therapy, postmenopausal, or if you've had ovarian failure, is to prevent bone loss. Because once the estrogen has stopped being produced in the body, such as a postmenopausal woman, bone loss accelerates. Okay, so estrogen stimulates and maintains the bones in women. So osteoporosis really accelerates after, or can become very common after menopause. Estrogen also maintains the tissue of the vagina, of the vulva, and without it, you can get all kinds of symptoms. You can get vulvar atrophy, which is thinning of the tissue of the female genitalia. You can get atrophic vaginitis, meaning the thinning of the tissue of the vagina that was maintained by estrogen. You can start to develop urinary incontinence postmenopausally. Another indication, we'll come back to the uterine bleeding in a minute, but another indication is if you're born with hypogonadism. So say you're a child and you've been diagnosed with a syndrome that causes reduced estrogen production, whether it's from your pituitary or from your ovaries. There's something that's causing estrogen not to be produced. Well, you would be a candidate for estrogen replacement. Uterine bleeding and uterine hemorrhaging. So sometimes women can have very abnormal periods, and they can come in with really heavy bleeding from what's called either dysfunctional uterine bleeding, DUB, that can actually lead to uterine hemorrhaging, so bleeding that just won't stop. And that is an indication for intravenous estrogen, because estrogen grows the endometrial lining. Okay, so it stabilizes and grows the endometrial lining. In particular, it grows it. Okay, so if someone's hemorrhaging, IV estrogen can actually stop the endometrial hemorrhaging. Okay, so what else is it going to do if we give someone estrogen? Well, there's a negative feedback to the pituitary, so it's going to turn off FSH and LH. It's going to stop the bone from being resorbed, so broken down by the osteoclast, because you're introducing estrogen. It's going to support and maintain the female reproductive tract. So to avoid atrophic vaginitis, which is dry, thin skin or mucosa in the vagina, which can cause painful intercourse. It can cause irritated vaginal mucosa, which can then lead to bleeding. And it's gonna maintain. It can potentially help avoid urinary incontinence by maintaining the tissue there as well. What are the adverse effects? So giving someone estrogen by itself is going to stimulate the endometrial lining. Okay, so we spoke about estrogen being it grows the tissue in the endometrium. So if you look at estrogen naturally when it's made in the body as part of someone's menstrual cycle, the first few weeks are really predominantly estrogen based, and then after release of the ovum, it becomes estrogen and progesterone. So estrogen really grows the endometrial lining to prepare it for an ovum. So if you're using estrogen, say postmenopausally, or because you had ovarian failure, it will still grow that endometrial lining, okay? And you don't want to stimulate the endometrial lining indefinitely, because whenever you stimulate something indefinitely, it puts you at risk to form endometrial hyperplasia and then finally endometrial cancer. There was also a study that came out about 25 years ago that showed that estrogen use in postmenopausal women put them at a slightly higher risk of breast cancer. And that's why a lot of estrogen was stopped in postmenopausal women, because of the small increase in breast cancer. So a lot of women had to go off it and endure menopausal symptoms because of that study. So not everyone went off it. It was a choice, right? But they were given the choice, and a lot of women were worried, and they stopped estrogen, what was called hormone replacement therapy, HRT. The other risk factor, or the other adverse effect with estrogen, so whether it's in a birth control pill or whether it's just taking estrogen postmenopausally, is increased chance of blood clots. Now this is vastly reduced in risk because we are using much lower dose of estrogen in birth control pills and also postmenopausally to control the loss of bone and reduce incidence of osteoporosis and also the menopausal symptoms. So it's still there though. And why does estrogen lead to blood clotting? Well, estrogen stimulates the liver to produce clotting factors, puts you at higher risk for clotting. So what's the contraindications for estrogen? Well, smokers who really wanted to be on the birth control pill, we were very careful with, because smoking thickens your blood and it puts you at risk for DVTs and PEs. And so smoking combined with a birth control pill or with estrogen is even a higher risk factor. So smoking is considered a contraindication. Pregnancy, well, you wouldn't take estrogen if you're pregnant. You're making lots of estrogen already. Heart disease, there was a small link to increased cardiovascular disease, and I think it was primarily the vascular part, which was increased clotting risk. Okay. You wouldn't use estrogen in someone who hasn't reached puberty, a female who hasn't reached puberty, unless they had some kind of ovarian failure, because estrogen is partly responsible for closing the growth plates. So you wouldn't want to close a child's growth plates prematurely. Uh, breast cancer that's estrogen dependent. So when somebody has breast cancer, we can test the breast cancer to see if it's estrogen receptor positive. And if it is, we actually use a medication called tamoxifen that blocks any estrogen from getting to the receptor to slow down the progression of the cancer. So we certainly wouldn't use estrogen in someone who either has a history of breast cancer or has proven estrogen positive receptors in their breast cancer. So in terms of responsibilities, discontinue prior to any procedure that causes extended immobility. Well, that makes sense because of the increased risk of clotting while on estrogen. Taking at the same time daily. That would be really important in terms of the birth control pill, right? Reporting menstrual changes. So if you have spotting and bleeding on the birth control pill, or if you have missed periods, that would be important to report. Could be pregnant. And also advising people about the risk of a potential DVT or PE, whether they're taking it as a birth control pill or for postmenopausal symptoms. There is a chance, especially if they decide to start smoking. And lastly, if you're using estrogen postmenopausally, or say for someone who had premature ovarian failure in their 30s or 40s, and they still have their uterus, which will be the majority of people, you can't give someone estrogen by itself. You need to give progesterone with it. And that comes back to the increased risk of uterine cancer if you just give estrogen by itself. The progesterone you can think of as a stabilizing hormone in the uterus, and it matures the tissue. So estrogen grows the tissue to prepare for a pregnancy. I'm talking about a menstrual cycle here. And then the egg is released, and then the second part of the menstrual cycle, progesterone starts to be produced. And this matures the tissue, stabilizes the tissue. Okay, so it reduces the chance of endometrial cancer, and that's why we use it in combination with estrogen if you needed to be on estrogen and you had a uterus. I hope that makes sense. So this is really just showing that where did we get estrogen from? Well, the brand name for estrogen is Premarin. Well, Premarin is, so that's a horse, right? A pregnant horse. So Premarin was obtained from the estrogen of a pregnant horse. And just remember, we're talking about external uses of estrogen, meaning we're giving it as a medication. We're not talking about the estrogen cycle. Even though I'm referring to it sometimes, we're talking about estrogen as a pill or as a patch or intravenously as a medication, whether it's for birth control pill or whether it's for postmenopausal symptoms or whether it's to prevent osteoporosis postmenopausally. We're talking about giving someone estrogen, just to avoid confusion. Okay, so what about progesterone? So we can also use this in a pill form. We can also use it as an injection. So progesterone is the other female hormone, and in birth control pills we definitely combine estrogen and progesterone. If you just gave estrogen to someone, not only would it not be good for their endometrial lining, because it would grow and grow and grow, and finally it would just bleed. because you didn't have the progesterone to mature it. So it's always added to birth control pills in combination with estrogen. Menopausal hormone therapy. So it would be added to the estrogen in menopausal hormone therapy if the person had a uterus. So let's just say someone had a hysterectomy and they don't have a uterus anymore. Well, then you can just give them estrogen by itself because there's no uterus to stimulate. Okay? What about this term dysfunctional uterine bleeding? So that term really refers to someone who has very irregular bleeding, heavy periods between their regular periods, very irregular periods to begin with. Like say they have a period every 6 weeks or 2 months, and they're heavy and cramping. So progesterone can be used, can be given to them because hopefully by now you understand that progesterone is a stabilizing and maturing endometrial hormone. So we can give someone, say, a week or 10 days of progesterone to stabilize their endometrial lining, stop the progesterone completely, and we only gave progesterone, and then let them have a full withdrawal bleed. Okay, so let them have a full period. So let me say that again. Someone with irregular periods, they're having heavy periods and cramping, and we just want to do a reset of the cycle. We can give someone 10 days or 14 days of progesterone by itself, stabilize the uterine lining, stop the progesterone after 10 or 14 days. They'll have a full withdrawal period, and hopefully the cycle will return to a normal cycle. Okay, so that's we do sometimes do that with progesterone. So endometriosis. So endometriosis is a condition where endometrial tissue is living and growing outside of the uterus, so outside of the endometrium. So it can be stuck on the fallopian tubes, it can be stuck on the ovaries, it can be stuck on the bowel, all these places outside of the endometrium. And estrogen can aggravate it because it makes things grow. It's going to make that tissue grow as well. Progesterone, being the stabilizing hormone, the maturing hormone, can stop it from growing and just maintain it. So it can control the symptoms of endometriosis. Okay. Sometimes progesterone is used to prevent preterm birth. Sometimes women are diagnosed with low progesterone levels and they recurrently have miscarriages. And progesterone is sometimes used to prevent that. In vitro fertilization, well, that's fertilization outside of the body, so you'll need hormones to help with the fertilization. Okay, so actions, a sex hormone involved in reproductive development and menstruation. Yeah, so now there's also birth control pills that are only progesterone. So Depo-Provera, under similar there, medroxyprogesterone is an injectable progesterone that gives 3 months of birth control effect. So it can be used in isolation. And why would we do that? For someone who, for example, isn't very compliant with pills and they forget their pills all the time, someone who just doesn't want to recall having to take their pill every day, or someone who can't tolerate the estrogen component of a birth control pill. Okay. What about the adverse effects? So breakthrough bleeding. So, I mean, some of this just depends on the balance of how much estrogen and progesterone you're providing, and if it's enough to maintain the endometrial lining. And if it isn't, then you'll get breakthrough bleeding. And for example, women that go onto the birth control pill, they're often given one particular birth control pill for 3 months. And it's not uncommon to have breakthrough bleeding or spotting in the first 1, 2, or 3 months. But typically after that, the birth control pill should provide regular periods once you stop taking the birth control pill. And then you have your withdrawal period, and then you begin the pill the following month. But sometimes it doesn't work that way, and you have continued breakthrough bleeding. And that's when it's time to follow up with your healthcare provider and talk about a different pill. And a different birth control medication. And it just depends on the amount of estrogen, the amount of progesterone, and the individual person. Okay? Amenorrhea. So if you took the birth control pill without having a withdrawal period, you would have amenorrhea. It has estrogen in it, it has progesterone in it. The body actually thinks you're pregnant. It's turned off FSH, it's turned off LH. So you would just not have a period, right? So these hormones can cause amenorrhea just by the body thinking that you're pregnant. You have estrogen and progesterone floating in your bloodstream. Your uterus seems to have a proper lining. The FSH and LH are at very low levels, so you have amenorrhea. Breast tenderness is from the breast tissue swelling and edema, and that's a typical symptom, say, in early pregnancy. Women notice that their breasts are tender, and it's from the hormones. Jaundice is because these hormones, including progesterone, stimulate the liver. Estrogen does. What progesterone does is actually it gives you a slowing down of the bile secretion. So it's called cholestasis. So slowing down of bile secretion, and that can lead to a backup of bilirubin, causing some jaundice. And progesterone can actually aggravate migraine headaches. Okay, so some women get terrible migraine headaches on the birth control pill. Okay, contraindications. In diabetes mellitus, I'm not sure if I don't think it's a contraindication. It can aggravate definitely patients with seizures, with migraines, and you would never use it in pregnancy, right? Pregnancy is it's being taken care of by the body with its own estrogen and progesterone. Now, in terms of responsibilities, you can definitely expect a withdrawal bleed if you've taken progesterone as a medication to do a reset of the endometrial lining, and then you stop it. And then there's a withdrawal bleed. Okay. The quarterly IM injection is referring to the medroxyprogesterone, the Depo-Provera, as a birth control pill. I mean, the one downside of Depo-Provera is that you can have side effects after the injection. So, and then you can't take back the injection. So most people tolerate it very well. It's just a thought at the beginning when you're getting an IM injection that it's not like you can go and just get it back, unlike a pill that you can stop very easily. Okay, so this slide is giving you a prototype oral contraceptive. So there's an estrogen and there's some form of a progesterone. So ethinyl estradiol is the estrogen, and norethindrone happens to be the progesterone in this combination. And by far the most common reason for using contraception in general would be to avoid getting pregnant. Definitely does not prevent STDs. There's some other indications though. If you are a woman that has heavy periods every month, so you have regular periods, but they're very heavy, and you become fatigued and tired, and you go for a blood test, and we find that your hemoglobin is 8.5. Well, you're not keeping up with the iron loss in the blood that's occurring every month. So we would definitely recommend that you go onto an iron supplement, but sometimes that's not quite enough because you're losing so much iron monthly with heavy periods. So heavy bleeding, but at normal times, is called menorrhagia. Okay, so you have regular periods; they're just very heavy. So a birth control pill can be used in that case to not change the regularity of the periods, but to control the amount of blood loss. It'll be much reduced when you're on a birth control pill, because the estrogen and the progesterone in the birth control pill will only build up the tissue so much in the endometrium, and then you'll have your regular period when you go off the birth control pill at the end of the month for those 7 days, and then you'll start the birth control pill again. So to reduce menstrual blood loss and also becoming anemic, we do use a birth control pill. Reduced cramping. So some women get severe menstrual cramps every month. They try ibuprofen. They try all kinds of anti-inflammatories because they can be effective in helping menstrual cramps. But sometimes women need to go onto the birth control pill to really reduce the menstrual cramps that are occurring every month. To protect against endometrial and ovarian cancer. So let's just go back a bit here. So the more that you cycle in the lifetime of all of your periods, starting from the time you started to begin menarche, say at the age of 13, all the way until you reach menopause, you're cycling every month. So you're stimulating the ovaries, you're stimulating the endometrium, and that runs a low risk, but it runs a risk of developing endometrial or ovarian cancer throughout your lifetime as a female. Birth control pills basically turn off the pituitary gland from stimulating the ovary, and they turn off the endogenous estrogen and progesterone in the body, and it's just supplying the estrogen and progesterone in the pill that you're taking. So you're actually reducing the number of overall cycles that you're experiencing, that your ovaries are experiencing, because you're turning them off. They're not releasing an egg every month. So if you're someone who has extremely strong family history of endometrial or ovarian cancer, one of the options is to be on a birth control pill. The other option, and this has been shown in studies, is that if you're women that have been pregnant many times have less overall risk because during their pregnancy they weren't cycling. right? They were pregnant. They weren't releasing an egg every month. So women with multiple pregnancies had a slightly lower risk of ovarian and endometrial cancer. Now, I don't think many people go on the birth control pill for this reason, but just to give you some history about why that indication exists there. Okay, so actions. Stops contraception by preventing ovulation. Yeah, right? It stops FSH and LH from being secreted by the anterior pituitary. Thickens cervical mucus. Absolutely. Progesterone does that. So it stops the sperm from getting into the endometrium. And altering endometrial lining to reduce the chance of fertilization. So, of course, the birth control pill doesn't act exactly the same as a woman's endogenous estrogen and progesterone. So, the endometrial lining won't be exactly the same to increase the chance of a fertile egg implanting. So lots of ways of preventing pregnancy. Thickening of the cervix, cervical mucus, reducing ovulation by blocking FSH and LH, and the endometrial lining is not quite the same. So adverse effects, these are basically all going to be blamed on estrogen. Thromboembolic events, that's DVTs and PEs, estrogen. Hypertension, estrogen. Don't smoke with a birth control pill. Increased risk of PEs and DVTs because of the estrogen. Breakthrough or irregular uterine bleeding can occur, and this is often because of the estrogen as well. So remember, the estrogen part of the pill is what grows the tissue within the uterus, and the progesterone is what stabilizes it. So if the estrogen content is too high in any particular pill, you'll grow the tissue too much, and some of it will start to break off, and you'll get irregular uterine bleeding. Okay? And often we have to change the birth control pill to adjust for that. Contraindications, well, pregnancy for sure, smokers for sure, greater than 35 is becoming a risk factor of increased risk of DVTs and PEs, history of any clots, such as a DVT or a PE, very high risk of breast cancer, likely not a good idea. Uterine fibroids are benign tumors on the uterus. They're not dangerous. Just that the birth control pill, because there's estrogen in it, will stimulate the fibroid to grow. So it may cause symptoms just because it's taking up more space in the pelvis. So it'll grow a benign fibroid to a larger size. And that's why after menopause, when there's typically no estrogen and progesterone, fibroids tend to shrink down and stabilize. Nursing responsibilities, so pregnancy test prior to starting, or the other option that we do is just start the first pill after the end of your period. So after the end of your period, you typically know that you're not pregnant. So if it's a predictable period and you've just gone through it, and starting the pill at the end of it, you know you're not pregnant. But the other option is to do a pregnancy test prior to starting. Definitely quitting smoking if you're a smoker. The cyclic administration, so the birth control pill comes in packages of 28 pills or 21 pills. If you get the 21-day pill, 21-day pack, well, they're all active, and then you go off them for 7 days, and you have your withdrawal menstrual period. If you get the 28-day pack, well, the last 7 days are just placebo. They're just sugar pills. And for people that don't want to forget to take a pill every day, they can get a 28-day pack. knowing that the last 7 days they're going to get their period because there's no hormones in them. Taking at the same time daily, mainly so that you don't forget. Missing more than 3 days, in a month in particular, it's going to become unpredictable in terms of the protection that it'll provide. And generally, you're going to start to get spotting through the month if you're missing pills, because if you're missing pills, the estrogen and progesterone will drop in the bloodstream, and the endometrial lining will start to shed, and you'll get a period. Okay, so if you know you've missed pills, then using a condom is a good idea, since you're likely not protected from getting pregnant. Okay, so this slide is on STDs, and just really a reminder that birth control methods, except really for condoms, are not effective in preventing sexually transmitted diseases. So really the only method is the latex condom that's been shown to reduce STDs. And if you look at the numbers here, chlamydia, so chlamydia is an extremely common bacteria that's sexually transmitted. Its name is Chlamydia trachomatis, and in men it doesn't give a lot of terrible complications. It typically gives you penile discharge, so it's kind of a clear jelly-like penile discharge in males. In women, sometimes you may not even know that you have it, because it can be within the vagina, very mild, clear discharge. It can actually give you PID, where it ascends into the uterus and the fallopian tubes and scars and damages the fallopian tubes. So pelvic inflammatory disease in women can be a result of any of these STDs. The next one, gonorrhea, which is from the bacteria Neisseria gonorrhea. In men, this is a bit more aggressive than chlamydia. This can give significant penile discharge, so very purulent pus discharge from the penis. It can actually ascend in the penis and cause some testicular issues and even epididymitis, which is a little sac next to each testicle that can get infected. In women, it can give a lot of vaginal discharge. It can also ascend in the female genital tract and cause pelvic inflammatory disease, which can permanently scar, again, the fallopian tubes, leading to infertility later in life. Syphilis, real name is, well, that is the real name, but the bacteria is Treponema syphilis, and this particular bacteria comes in stages. The first stage, or the primary syphilis that you see at the bottom there, that's the stage where you get the sores on the penis or within the vagina. In females, again, you may not see that unless the sores are external. In males, it's more obvious because it's already external, and that's the primary. That's primary syphilis, and they're typically firm. They're firm ulcers on the penis, and they're non-tender. And if ignored, they'll go away by themselves, and then you will get what's called secondary syphilis, which is typically uh, lymph node swelling throughout the body, under your arms, in your groin, um, with a low-grade fever, and a typical rash that occurs um, on your body, on the palms of your hands, and the soles of your feet. So that's secondary syphilis, and that can go on. So once, if that's ignored or not diagnosed, you go on to a latent phase where the symptoms just go away, and then months to years later, you can be diagnosed with tertiary syphilis, and that's a much more aggressive disease. It can affect the brain in particular. It can give a lot of permanent damage compared to primary or secondary syphilis, which, if diagnosed, is very treatable with antibiotics. And congenital syphilis is acquiring it through birth. So these are all relatively common STDs. Definitely chlamydia is the most common. Okay, so let's move on briefly to some male-related issues and medications. So this slide that's saying male menopause or andropause, which is interesting. So so males in their 50s and 60s can actually have a decline in testosterone levels, and we can measure that with serum testosterone, or even more accurately with what's called a free testosterone, a free serum testosterone, because most hormones in the body are bound to proteins. So in the serum, such as albumin and all kinds of different globins in the serum. So what we really want to know is the active part of the hormone. What is the free part that's not bound to protein? So we often will get a free testosterone or a free T4 level, and that gives us the exact amount that's actually just in the bloodstream without being bound. Okay, so let's look at some symptoms and complications of reduced testosterone levels. So decline in cognitive function or depression. So males can come in with depressive symptoms, and sometimes a testosterone level will be taken. There's definitely thinning of the hair and hair loss with being male, with having androgens, right? With having testosterone. Testosterone is responsible for maintaining muscle mass. So loss of muscle strength, loss of muscle mass can occur with diminishing testosterone levels. Increased fat mass and abdominal obesity. So testosterone tends to produce more muscle. Estrogen, which is the female hormone, tends to produce a bit more fat. And that makes sense because estrogen, so women are storing for potential pregnancy. So they may require that energy storage. Okay, I mean, males and females store fat, but I'm just trying to explain the differences between the different sex hormones. Reduction in bone mass, osteoporosis, that can happen as your testosterone levels diminish. Reduced sexual desire, shrinking or testicular atrophy from reduced levels of testosterone, right? Gynecomastia. Why gynecomastia? Well, when you have less testosterone in your bloodstream as a male, you still have some circulating estrogen that can be produced in your adrenal glands, So now the balance has shifted a bit more to estrogen, so you have the potential to have small breasts, gynecomastia. Okay, so these can all be symptoms of lowering testosterone levels in your 50s or 60s. And sometimes people will have low testosterone levels and are willing to try uh, testosterone as a medication to help their symptoms, right? And testosterone comes as a patch, as a pill, as an injection. So there's many options, there's many routes to administer testosterone. And that's what the next slide will be about. Okay, so testosterone as a drug. So it falls into androgens. Okay, so the main male androgen is testosterone. Okay, so it can be used for hypogonadism, so small testicles or immature testicles that are non-functional. Testosterone can be supplied as a medication to supplement that condition. Delayed puberty in males. So if testosterone is felt to be the factor in delayed puberty, then it can be administered as a medication. And again, I think I mentioned before, pills, injection, or patches. And then probably the most common is as an androgen replacement for male menopause. Okay, which again, in your 50s and your 60s, there's potential. I don't think it's as common as female menopause, where the average age of 50 is when most females stop having their periods and stop producing significant amounts of estrogen and progesterone. So the actions of testosterone, well, it's a sex hormone. It's involved in reproductive development and maintenance of male sexual characteristics, right? So the muscle mass, the hair distribution, the I want to mention something about all of these hormones that we've been talking about, whether it's testosterone, progesterone, or estrogen. These are all steroid-based hormones, okay? And there's a lot of hormones in the body that are protein-based, but these are steroid-based, so they go into the cell and have direct action within the cell, compared to protein-based hormones or peptides. They tend to have a receptor on the cell membrane. Okay, sorry, I went off a bit there. Okay, so let's look at the adverse effects of administering testosterone to someone. Well, testosterone being the male hormone, there's potential for increased aggression when this is administered. In fact, there was a study years ago that went and did tests in many prisons and jails throughout North America. And it was found that a lot of the prisoners, I mean a higher percentage, I shouldn't say a lot, but a higher percentage than the general population had a genetic defect where they had two Y chromosomes. So a male is usually XY and a female is XX. Well, it was found that XYY was found in a higher percentage in jails and prisons. And that makes sense. Two Y chromosomes, more testosterone production, higher and increased chance of aggression. Okay? As well, when you administer testosterone, acne. So facial acne, acne of the back, which can become what's called nodulocystic acne. So very severe cysts of acne can occur with testosterone, and that's why boys tend to get acne, and severe acne, much more than girls. Increased hair growth can be from administering testosterone to someone. Closing growth plates. So if you're giving testosterone to a younger child, it can close the growth plates prematurely. Okay, because testosterone is one of the hormones that starts to be produced at puberty, and it's partly responsible for closing the growth plates in males. Okay, just like progesterone, you can get a mild hepatitis, a cholestatic hepatitis, meaning the bile is not flowing well, and some of it's backing up into the bloodstream and giving you jaundice. Testosterone can mess with lipids, with your lipid profile, HDL, LDL. You can get abnormal lipid profiles that can be unhealthy. So you can get elevated LDL levels. So that's something to take into consideration, because that can lead to cardiovascular disease or put you at higher risk for cardiovascular disease. The next one, very important. Testosterone produced when given as a medication, or even if you're not taking it as medication, produced by your testicles, it stimulates the prostate gland. So when we give testosterone as a medication, we tell people you are at higher risk of developing prostate cancer because we're going to stimulate the prostate with this medication. And lastly, testosterone will stimulate the bone marrow to increase hemoglobin levels, polycythemia, higher hemoglobin levels in the bloodstream because of stimulation from the testosterone. Contraindications, well, definitely prostate cancer. Breast cancer is relatively uncommon in men. If you had it, we wouldn't want to stimulate it in any way, so we wouldn't give you injections of sex hormones. But definitely prostate cancer, which is extremely common in males, if you have a history of it, or you have active prostate cancer, we definitely wouldn't give you testosterone. Congestive heart failure, because testosterone is an anabolic steroid, meaning it's going to build up muscle mass. It's building up more protein in the body. It's going to make the heart work harder. So if you have congestive heart failure, that's probably not a good idea, because the heart's going to have to work and produce a higher cardiac output. And then, of course, liver disease. Well, progesterone or testosterone can cause a mild hepatitis, so we would avoid it in someone with liver disease. So under responsibilities, yeah, definitely if you were handling testosterone, to wash your hands after, because it can get absorbed through the skin. Taking weights is important, because you will likely put on muscle mass with testosterone. And also patient education about the adverse effects. In particular, you're at higher risk of acquiring prostate cancer. You're at higher risk of higher levels of hemoglobin, of thickening your blood a bit by the higher hemoglobin levels. And you're at higher risk of abnormal lipids in your bloodstream because of the medication we're giving you. Okay, I hope that helps. Okay, so on to BPH, benign prostatic hypertrophy. So very common in males in their 50s, 60s, and 70s. So I usually think of the prostate as a small apple with the core taken out, and that's where the urethra goes, right? So At the top part of the prostate, or the small apple, is where the bladder sits. And at the bottom part of the prostate, small apple, is where the base of the penis begins. And the urethra starts at the end of the where the bladder drains into the prostate, so the prostatic urethra, and it continues all the way down the penis to the outside world, so the penile urethra. So normally there's a very open lumen inside the prostatic urethra, and urine has no problem getting from the bladder through the prostate, down the penis, and out. Because the prostate is stimulated and it grows through adult life, partly because of testosterone, but that's the reality of having, needing testosterone for other systems in our body. We end up stimulating the prostate and causing it to grow. And when it grows, it doesn't always grow in a cancerous way. It grows just in a hypertrophied way, non-cancerous sometimes. And it can squeeze on the prostatic urethra and lead to obstruction. And because you have an obstruction in the lumen of the prostatic urethra, you have reduced urine flow. So you can't empty your bladder very well. So let's go through a typical day of someone who has BPH. So let's start in the evening. So they have their meal, they drink something with their meal, they get ready for bed a couple hours later. They try to empty their bladder, but they can't because it doesn't fully empty anymore. And so what happens through the night? Well, they never really emptied their bladder, so they don't sleep through the night anymore. The bladder fills up much more quickly because urine was already left in the bladder, but never fully emptied. So they get up 2, 3, 4 times per night, and that's called nocturia. So having to urinate through the night, nocturia. And then they wake up in the morning, and the same thing kind of continues through the day, where they have a weak urine flow. Sometimes patients will dribble with BPH. They'll tell you that their urine flow is much weaker than before, and that they're getting up 2 or 3 or 4 times per night to urinate small amounts. Okay, so BPH is not a cancerous condition. Now, prostate cancer is also extremely common, but we won't talk about that right now. But let's look at some medications to treat BPH, as opposed to just heading right to surgery. Because the inside of the prostate can be cored out with a cystoscope, with a device on it, where it cores it out, almost like coring out an apple. But it's a surgical procedure. You tend to get quite a bit of bleeding with it. So it's done frequently. It's called a TURP. So transurethral resection of the prostate. So transurethral resection of the prostate, a TURP. But there's medications that can be tried first. Okay, so let's look at a medication for BPH, benign prostatic hyperplasia, which is what we were just talking about on the previous slide. So finasteride, or Proscar, which is a medication that stops testosterone from converting into an even more active form called dihydrotestosterone. So it blocks testosterone from becoming its more active form, dihydrotestosterone, which then stops it from stimulating, or because it's not being converted to this more active form, it's not stimulating the prostate as much, and it can gradually shrink it. So what about male pattern baldness? Well, if you can also reduce dihydrotestosterone with this drug, because it blocks the conversion of testosterone to dihydrotestosterone, well, you're not going to get as much male pattern baldness, because the male pattern baldness is from the dihydrotestosterone. So really, these are the two indications for finasteride, or Proscar. So Proscar is the brand name for when it's used for the prostate, and Propecia is the brand name when it's used to grow a bit more hair and avoid male pattern baldness. So it has modest effects for increased hair growth. It has some, but it's not like you get a full head of hair back. So the action, just as we said, it reduces the usable testosterone, the dihydrotestosterone, and this will cause the prostate to gradually shrink in size, typically over many months, often 6 to 8 months. So it's not an immediate shrinkage, and it's not an immediate effect on benign prostatic hypertrophy and the difficulty urinating either. It can take many, many months. And the other action is increased hair growth by the same mechanism. So what are the adverse effects? Well, if you're reducing the active testosterone, dihydrotestosterone, then you could get decreased interest in sexual activity, decreased stimulation to the testicles, so that'll reduce the semen amount, the ejaculate volume, and also because you've reduced the balance between testosterone and estrogen, you've actually shifted it to estrogen because you've lowered the active testosterone levels. You can get some breast swelling from it. Contraindications, well, definitely pregnancy. Actually, well, no, I shouldn't say women never take this. Women do take this for a particular reason. Women with abnormal hair growth can be offered this drug to see if it can cut down on their abnormal hair growth. But definitely not in pregnancy would you take this drug, or in any kind of liver disease you wouldn't take this. So responsibility. So this is a long-term treatment for BPH. It's not an immediate solution. It can take, as I said before, half a year or longer to start to shrink the prostate. And I think that's all we'll say about finasteride. Okay, so don't think of it as a quick fix for BPH and the symptoms that go along with it. Okay, so the next drug we're going to review or discuss is tamsulosin, or the brand name's Flomax. And you've seen this group before. These are alpha-1 blockers, prazosin, terazosin, and they're used for blood pressure control, right? They block the alpha-1 receptor in the blood vessels, in the small arterioles, and vasodilate the systemic circulation. So tamsulosin will still do that, but it is used as well for its other effect, which is to relax the smooth muscle in the prostate and the bladder neck, and allow for increased urinary flow. So it'll still lower blood pressure, but it's been marketed more for benign prostatic hypertrophy because of its other alpha 1 antagonist effect. So really, because of how it works on the blood vessels is where you're going to see uh, the adverse effects. So potential hypotension, dizziness. Well, dizziness in this case, we're referring to that your blood pressure is dropping. Orthostatic hypotension. So when you get up too quickly, the blood doesn't have time to reach your brain, and you get orthostatic symptoms and dizziness. First dose phenomenon, where the first dose is a bit unpredictable in terms of how much power and how much effect it's going to have on your system. In problems with ejaculation. So we can talk about this just so it's easier to remember. It's an alpha 1 blocker, so it relaxes the smooth muscle in the upper prostate and the bladder neck, so it doesn't allow that valve to close as easily, which is great for urinating. But when you ejaculate, the semen is coming into the urethra, and some of it now, because the valve is a bit weaker going back into the bladder, it can go into the urethra, and instead of going down through the penis only, it can go up into the bladder. So that's called retrograde ejaculation, where some of it goes upwards into the bladder. It's not a big deal unless you're trying to get pregnant. Then it's a bigger problem. But otherwise, it's not a huge side effect. Contraindications: pregnancy, renal and liver disease, mainly just because of excretion. Nursing responsibilities. So this medication, again, you would try this at nighttime first, just because of its first dose phenomenon. So you try a nighttime dose, see if their blood pressure gets low, see if they have orthostatic symptoms prior to switching it to a daytime dose. So once a day pill, again, start slowly with these medications, although this particular one is a fixed dose. Tamsulosin comes in one dose, and you don't typically increase it for BPH, you just give that one dose. Unlike all the other alpha blockers, which is start slow, or start low and go slow. You start at very low doses and you go up slowly. And finally, if someone were to be taking this to help their BPH and they were started on finasteride, then once the finasteride has become effective, or it's shrinking the prostate and it seems to be effective, then they may not need the tamsulosin anymore. Tamsulosin works much, much faster, so they can have immediate effects that they can urinate better. But 6, 9, 12 months down the road, they may just be able to take the finasteride and not have to use the tamsulosin. So it just depends on their symptoms. Okay, so sildenafil is the next medication. Brand name is Viagra. So sildenafil is indicated for erectile dysfunction. So weak, ineffective erections, or pulmonary hypertension. So because it causes vasodilation in some of the arterial beds, it allows increased flow, say, to the penis, allowing for an erection to be maintained. It also helps with a condition called primary pulmonary hypertension, which we don't really know the cause of, but the underlying problem is that the small blood vessels in the lungs, the tiny little arterioles and capillaries, are very constricted and damaged. We think it's an autoimmune disease, and it results in high blood pressure in the pulmonary artery, which can then lead to right heart failure because of all the pressure that the right heart is having to pump against. So this helps with vasodilation of the small arterial beds in the lungs and reduces the pressure in the pulmonary artery. So its action is really through a little molecule called nitric oxide. So it increases the effects of nitric oxide, which then results in vasodilation and increased flow. Within the penis, it'll lead to an erection. In the lungs, it'll reduce the pulmonary artery pressure. The main side effects of this drug are priapism, which is an erection lasting longer than 4 hours. And that's an issue because if the erection continues, there's really no flow going into or out of the penis. So it's like an ischemic penis. It's not getting blood supply. So if left, it can damage the penis and lead to permanent impotence. So longer than 4 hours, the patient would need to go somewhere to seek help. You can get visual changes, different colors in your visual fields, and you can get alterations of your peripheral field. So it changes how, for some patients have complained of changes in their peripheral fields and color changes when using this drug. You can use this drug with cardiovascular disease. There have been a couple of reports of people getting a myocardial infarction while on Viagra or on sildenafil. But in general, patients with cardiovascular disease, they're advised about the risk, but it's not contraindicated. You can still use sildenafil. The only contraindication is if you have cardiovascular disease and you're taking nitroglycerin. So nitroglycerin in any form, whether it's a tablet under your tongue, a patch, any form of nitroglycerin cannot be used with sildenafil. Nitroglycerin leads to vasodilation of the arterioles and the veins, and in combination with sildenafil, which also leads to significant vasodilation, you can have severe hypotension and death, and there have been deaths from this combination. So usually we advise patients to take this 30 minutes to 2 hours prior to sexual activity, and obviously to report any visual changes or any issues with or any concerns related to an erection lasting beyond 4 hours. Okay, so clomiphene. So now we're talking about an infertility drug. We've gotten away from sildenafil and other medications for men, and now we're back talking about a medication that females use called clomiphene or Clomid. And the indication for this is infertility that's related to the woman not ovulating, so not releasing an egg. Okay, so it's not going to help all forms of infertility uh, because this medication is going to stimulate the hypothalamus, which is then going to stimulate the pituitary gland, which will then stimulate the ovary to release ovums or to ovulate. Um, so other forms of infertility, whether it's um, scarred scarred fallopian tubes, something wrong with the uterus, it won't help any of those. It's really just for inability to ovulate. And as I mentioned, it stimulates the hypothalamus to release the hormone that's going to be sent to the pituitary gland, GnRH, so gonadotropin releasing hormone. And when it gets to the pituitary gland, it's going to cause stimulation and release of follicle stimulating hormone and luteinizing hormone, which will then go to the ovaries and stimulate the ovaries to ovulate. So this medication is usually taken on about the 5th day of someone's cycle. Okay, so they had their period, and now 5 days in, they're going to take this medication. And the medication is taken for approximately 5 days. So really, it's in that window where you want to really stimulate the ovary to try and release, to try and ovulate. So what are the symptoms? So you have a hormone that's really, in the end, causing stimulation of the ovaries. So you can get pelvic discomfort because you're really causing the ovaries to be stimulated with this drug. You can get bloating. You can have like pelvic pain, pelvic discomfort. It can also cause some breast tenderness, some flushing. Headaches aren't unusual with this medication. And a lot of the symptoms will be not only from overstimulation of the ovaries, but from all the hormones being released, right? So the bloating, the breast tenderness, that's from all the hormones being released. What about the contraindications? So definitely not in pregnancy. Wouldn't use a fertility drug in pregnancy. Abnormal vaginal bleeding. Well, if you don't know why someone's having abnormal periods or abnormal vaginal bleeding, they wouldn't receive clomiphene until it was diagnosed. Other hormonal abnormalities, adrenal gland, thyroid problems. These hormone systems are interrelated. So if there's problems with the hormone or with the thyroid or the adrenal gland, we're not going to stimulate another hormonal system without finding out what is going on with those other glands. And the other thing is, the other condition is if you have ovarian cysts that are seen on ultrasound. When you have clomiphene, it will stimulate the ovaries so much that it can aggravate and enlarge the ovarian cysts significantly. Okay. In terms of advice and responsibilities, telling the patient that they have a significant chance of multiple births when on clomiphene. So if they were to get pregnant, there's a 10% chance, 1 in 10, that they could have twins. They need to follow their calendar, their ovulation calendar very closely. They need to know when day 5 is. they also need to realize that uh, this this 5-day course per month can happen in other months. So it's not necessarily going to be successful the first month that it's used, but there's subsequent months that it can also be used, because people are very disappointed when after having gone through this and having ultrasounds and blood tests that it's not that it wasn't effective that month. So they need a bit of counseling to realize that this isn't a guarantee that this month you're going to become pregnant. This medication is taken by mouth. By mouth for those 5 days in the cycle. Okay, so in this next part, we're going to talk about some medications related to labor and delivery. So remember, there's some times where we want to slow down contractions during labor. It's usually because it's a premature labor, and the infant is very young, or the fetus is very young, and there's risk of delivery of a premature infant. So medications that we'll get into, I'm sure you've heard of some of these before. Magnesium sulfate can sometimes slow down labor. Terbutaline, which is a beta-2 agonist that can be used in asthma, can also be used to try and slow down labor, because there's beta receptors on the uterus, and when stimulated, they actually reduce the contractions of the uterus. So we're taking advantage of that effect and using terbutaline to try and reduce preterm contractions. What about medications that might induce labor? So there's a medication that can ripen the cervix, soften the cervix, induce labor to start, called misoprostol. It comes as a pill. It comes as a gel that you can actually directly put on the cervix, and that can sometimes induce the beginning of labor. And then there's a medication, and it's also a hormone in the body, called oxytocin, that can increase contractions of the uterus. So there's a number of different medications that can be used, and we'll get into some of them in this part of the module. Okay, so oxytocin. The ones that you're seeing under similar, they're similar in the sense that they are used to help with inducing labor, such as misoprostol, but they're not similar in terms of how they work. Okay, so they're similar as a whole, that they're used in helping labor progress. So I just didn't want you to get that confused, since I mentioned misoprostol on the slide before. Okay, so oxytocin. So we can start oxytocin drips, and we often use it after giving misoprostol. So we can soften the cervix and get it ready for dilation, because the cervix has to go basically from a little pinpoint hole to about 10 centimeters in size, right? So that's a lot of stretching. So we can soften the cervix with misoprostol gel, and then start an oxytocin drip to start to stimulate and increase contractions. So under indications, induction of labor for sure. It's going to induce contractions, and not only that, but enhance the force of the contractions to help with delivery. It can also be used postpartum, so after the delivery, to help deliver uh, the placenta, right? So with continued contractions even after delivery, that can help with forcing the placenta to come out. And another common indication is after the delivery, if there's significant amounts of bleeding, so postpartum hemorrhage, um, oxytocin can be used to force the uterus to really contract down and stop that bleeding that's happening within the uterus. Okay, so there's labor induction and increased contractions, but there's also postpartum indications for this as well. So it's a uterine stimulant, increases the strength and frequency of the contractions. Um, and remember, oxytocin is also produced in the hypothalamus, stored in the posterior pituitary, and obviously would have this identical effect, but we're using it as a drug here, and we're controlling the dose so that we can get the exact response that we're looking for. So under adverse effects, well, if you give enough oxytocin, the uterus can contract so forcefully that you can actually rupture the uterus. Or you can have overstimulation of the uterus, too many contractions, tachysystole of the uterus, where there's just too many contractions coming at once. And if there's so many contractions occurring with such force, the placenta can tear away from the uterine wall, from the endothelial, the endometrial wall, and that's called placental abruption. Okay, so think of this drug that's really forcing the uterus to work hard, contracting. Sure, it could rupture it. It could force it to contract too frequent and too hard. That can lead to the placenta tearing away from the wall. Okay, so contraindications. Well, if the cervix isn't ready to open at all, that's not great because now you're just forcing the uterus to contract against a closed cervix. The next one, active herpes. So active genital herpes is referring to herpes in the birth canal. And if a woman has active genital herpes, usually she's going to have a cesarean section, no matter what else has happened, because you don't want the infant that's being delivered to acquire genital herpes. Okay. History of multiple births or uterine surgery. So if you have multiple births, oxytocin can complicate things because now you have two placentas, two fetuses, or potentially two placentas, and it can, with these forceful contractions with two fetuses in there, it can cause complications. Previous uterine surgery. Okay, well, there's another risk factor for uterine rupture. So that would be a high risk using it then. A umbilical cord that's prolapsed down through the cervix and is hanging out, and now you're forcing the uterus to contract, can really cause further problems with that prolapsed umbilical cord. Okay, so when the umbilical cord prolapses down through the cervix, it can get twisted, and the fetus can lose its blood supply and lead to fetal death. Forcing the uterus to contract even harder can cause even more blockage within the umbilical cord. So we wouldn't use it in that case if we realized it was a prolapsed umbilical cord. Nursing responsibilities. So This is definitely a drug that's titrated, meaning you start at a low dose and you go up slowly to see its effect. Uh, the uh, the the pregnant patient will have a monitor on to see the force of the contractions, to see the fetal heart rate. Um, her cervix will be checked on a regular basis to see that the cervix is gradually progressing to open. Because as I said, it has to go from 1 centimeter to 10 centimeters. Okay, I think that's it for this one. Okay, so terbutaline. So remember, it comes as an inhaler for asthma. It's a beta-2 agonist. So this is, again, under similar, you're going to see magnesium sulfate. Sure, that can try and reduce preterm labor contractions. Nifedipine has been tried. It's a calcium channel blocker to try and slow down preterm contractions. So just realize that these are similar drugs that are used for preterm labor, but they're not in the same group. Okay. Okay, so terbutaline. So this is really just to try and delay things. It's not going to shut off completely the labor very often. It's just going to delay it so other treatments can take place during those 1 to 2 days that you've slowed down the contractions. Okay. So beta-2 receptors lead to relaxation of the uterine muscles. Okay, and that's what we want in this case in preterm labor. All the effects are going to be from beta-2 agonists working elsewhere in the body as a sympathomimetic. So tachycardia, okay, yep, it's a beta agonist. You can get your heart rate's going to go faster. Palpitations, you can get chest pain from all the palpitations and the tachycardia. Hypotension can occur because there's beta-2 receptors on the blood vessels going to all the muscles in the body, and they lead the terbutaline vasodilates the blood vessels going to the muscles. Okay, so you can get hypotension due to that effect. Hypokalemia, because beta-2 agonists, when they interact with cells throughout the body, they force potassium to go into the cells. So you get hypokalemia in the serum. Okay. Hyperglycemia, that's the sympathetic response to glycogen in the liver to release glucose. So you'll get hyperglycemia, right? Glycogen converts to glucose with sympathetic activation. Arrhythmias, same thing as tachycardia. If tachycardia progresses, you can get abnormal rhythms because you're overstimulating the heart so much with a beta agonist. Okay. Nursing responsibilities, definitely monitoring, again, uterine contractions. You want to see them slow down and reduce in contractility. Fetal heart rate monitoring, you want to see that the fetal heart rate is in a normal range, which is an indication that the fetus is still happy in there, right? If we see huge changes in fetal heart rates, that can be concerning for fetal compromise or something that's happening that the fetus is not happy about. Monitoring the vital signs of the mother, heart rate, blood pressure is very important. And typically this is used as a subcutaneous injection or even IV. It's not usually given as a mask or as an inhaler that we would use in the setting of asthma, for example. Okay, and this next medication, betamethasone, is a steroid. Um, and the reason why it's in this part of a module is that we use steroids for so many things we won't get into right now. But one of them is in preterm labor. The big concern with delivery of a premature infant is respiratory immaturity. So their lungs are immature. They may not be able to breathe on their by themselves, and they may end up on a ventilator. Okay, so very premature infants can get three things commonly. So they get respiratory distress, an inability to ventilate on their own, requiring a ventilator, as I just mentioned. They can get intracerebral hemorrhages in their brain due to immature blood vessels. And they can get a severe condition in their bowel called necrotizing enterocolitis, NEC for short, NEC. And that has to do with immature and poorly developed blood vessels that's supplying the bowel. And because they're not fully mature, it leads to ischemic bowel, so death of the bowel due to poor blood supply. Okay, so in this case, we're talking about a medication. So that was just an aside. In this case, we're talking about giving a medication to the mother to stimulate the fetus to accelerate the production of surfactant in the lungs, so that they have a higher chance of being able to breathe by themselves when they're delivered. And it takes a bit of time to work. It's not instantaneous when given to the mother. So it can take a day or two to start to develop. So the longer you can safely stop premature labor, the more effect the betamethasone will have on the lungs. Okay, so indications: reduced neonatal respiratory distress syndrome in preterm labor. And this can also reduce the intracerebral hemorrhage that can happen in these premature infants as well. So it's actually used for both of these reasons, right? For the respiratory distress and also to reduce the hemorrhaging in the brain. And the action is that it stimulates production and release of lung surfactant, which is really going to help the lungs expand when the fetus is born, when the infant is born. It's going to help the lungs expand and to breathe more easily. The next topic to discuss is that, so this is given in 2 doses, right? So betamethasone is given as an IM injection to the mother. 2 doses spanned 12 to 24 hours apart. And really the intention is fetal surfactant production. Okay, and it's recently been realized that it also reduces the intracerebral hemorrhage rate in these very premature infants. Okay, so fentanyl, so an opioid medication, a very strong intravenous opioid narcotic, and used for all kinds of painful conditions, especially in the emergency room, in the intensive care. Fentanyl is used all the time. Can use it as well, as you see here, in active labor, right? And it works the same way as any other narcotic or opioid. It binds to opioid receptors and reduces reduces the pain. So, what are the issues? Well, with an opioid, there's always a concern of respiratory depression, right? So whenever you think of opioids, if given an overdose, respiratory depression, right? And of course, hypotension as well. So in this case, it'll be neonatal and mother respiratory depression. Possible maternal hypotension, because opioids can drop your blood pressure. That can lead to tachycardia to try and respond to the hypotension. Over sedating the mother. Nausea and vomiting is common in basically every opioid. It's always a risk when we give a dose of morphine or fentanyl that we're going to make the person nauseated and vomiting on top of what they already have. Okay. And of course, and remember, the over-sedation is very common as well. But in general, we're thinking of giving someone an IV dose of an opioid. We're thinking respiratory depression and hypotension. And if we give too much, we'll come back and see them, and they'll be overly sedated and possibly even nausea or vomiting. Okay. So contraindications, history of dependence. So if you have someone who has a history of dependence on opioids, probably not going to use this. If they're making an effort not to be on opioids, say they were dependent on opioids, we wouldn't add this to the mix. And they probably would ask not to receive fentanyl because of their history of dependence. Okay, nursing responsibilities. So really what this is doing is giving some pain relief during active labor. So we're going to monitor the fetal heart rate. We don't want to give this very early in labor. So we want to see that there's been some progression of labor, so that the cervix should be a bit dilated, 4 centimeters. And the reason for that, if we give fentanyl early, it's going to reduce the force of contractions. It can oversedate the mother, so she has a difficult time with or cooperating with the contractions. Reversal agent, I'm sure you're aware of by now. It's naloxone. So we want to monitor the contractions, especially if they're receiving fentanyl. So avoiding early, we spoke about, because of reduced contractions, over-sedation of the mother. Giving fentanyl very late in labor can be a problem, because now what's going to happen is, say there's a delivery 15-20 minutes later, the infant or the neonate is going to come out very floppy, over sedated. So because the infant also received the fentanyl. So it's a bit of a fine line, giving it in between and giving it in small amounts, not too early and not too late. Okay, and this slide is just showing you it doesn't show the magnitude of how much that cervix has to dilate. Well, the numbers do, but the size doesn't. But it basically has to go from 1 centimeter to 10 centimeters, which is an incredible amount of stretching, so that the head of the fetus can then get into the birth canal. So it really is amazing. And I think that is it for this module. I'm sorry it's gone longer than I expected. 3 hours and 15 minutes. There seemed like there was a lot of information. I've tried to keep most of them per week to about 2 hours and 15 minutes to 2.5 hours. This one just went on longer, but I hope it gives you more information.